Hello everyone, and welcome to another stream of Advanced Pathophysiology. Today we are continuing Chapter 33, the Alterations of Cardiovascular Function. As per usual, my pages will not line up as yours, so just take note that we will go through the entirety of this chapter. Um, so we'll jump right into it. Starting off with cardiovascular disease is the leading cause of death in both the United States and worldwide. Disorders of the veins, arteries, and heart wall compromise the scope of cardiovascular disease. Current understanding of the pathophysiology of cardiovascular disease is focused on genetic, neurohormonal, inflammatory, and metabolic mechanisms that underlie tissue and cellular alterations. So, diseases from the vein. Big ones here are varicose veins and chronic venous insufficiency. Chronic venous disease manifests along a continuum from asymptomatic telangiectasis, telangiectasis, not sure how to pronounce that, telangiectasis, to varicose veins, to chronic vascular insufficiency. I'm going to just call it telang, are small, widened blood vessels visible in the skin. A varicose vein refers to a condition in which venous blood has pooled, producing distortion of the veins, leakage, increased intravascular hydrostatic pressure, and inflammation. Varicose veins result from incompetent valves, venous obstruction, muscle pump dysfunction, or a combination of these conditions. The increase in venous hydrostatic pressure is associated with an increase in transforming growth factor beta, or TGF-beta, and basic fibroblast growth factor, or BFGF, in vessel walls, resulting in permanent remodeling of the vessel. An altered ratio of prostacyclin to thromboxane A2 with potential for clotting also occurs. Risk factors for developing varicose veins include gender, which includes women that are much more at risk than men, pregnancy, increased weight, increased age, leg trauma, sitting or standing for long periods of time, and family history. Symptoms include visible distended veins, itching, burning, or throbbing around lower leg veins, and muscle cramping or pain in the lower legs. Varicose veins can progress to chronic venous insufficiency, which is defined as persistent ambulatory lower extremity venous hypertension. Venous hypertension, circulatory stasis, and tissue hypoxia lead to an inflammatory reaction in vessels and tissues. These processes cause lower extremity edema, pain, skin changes, hyperpigmentation, and lipodermatosclerosis and necrosis from venous stasis ulcers. Infection can occur because poor circulation limits immune and inflammatory responses, especially as a complication of reparative surgery. Treatment across the spectrum of chronic venous disease may include recommendations to lose weight and decrease time spent standing and or sitting, leg elevation, physical exercise, and use of compression stockings. If conservative treatment is not successful, endovenous ablation or foam sclerotherapy may be recommended. Both are associated with less pain and faster recovery compared to endovenous laser therapy and surgical stripping. Deep vein thrombosis. Venous thromboembolisms, or VTE, include deep venous thrombosis, or DVTs, and pulmonary emboli, PEs. DVT is a blood clot that remains attached to a vessel wall, usually in a single site of the lower extremity. A detached thrombus is a thromboembolus. Venous thrombi are more common than arterial thrombi because flow and pressure are lower in the veins than they are in the arteries. The American Heart Association estimates that about 2 million people in the US will have VTE annually, with approximately 44,000 deaths. Three factors, termed the triad of Virchow, promote venous thrombosis. Venous stasis, associated with immobility, obesity, prolonged leg dependency, age, congestive heart failure; venous intimal damage related to trauma, venopuncture, and IV medications; and hypercoagulable states from inherited disorders such as smoking, malignancy, liver disease, pregnancy, oral contraceptives, hormone replacement, hyperhomocystinemia, and antiphospholipid syndrome. Virtually everyone who is hospitalized is at risk for DVT, especially those with orthopedic trauma or surgery, spinal cord injury, age older than 60 years, and obstetric or gynecologic conditions. Individuals with malignancy, especially ovarian and pancreatic cancer, and women who are pregnant are at also significant risk. The most common heritable hypercoagulable states are abnormal factor V, Leiden, and prothrombin gene variant, the 2021-0A, both of which predispose patients to DVT. Other less common causes are deficiencies of the endogenous anticoagulants, protein C, protein S, and antithrombin. Accumulation of clotting factors and platelets lead to thrombus formation in the vein, often near a venous valve. Inflammation around the thrombus promotes further platelet aggregation, and the thrombus grows proximally. Most thrombi eventually dissolve without treatment, but untreated DVT is associated with a high risk of thromboembolization of a part of the clot from the leg traveling to the lung, resulting in a pulmonary emboli. In up to one-third of individuals with DVT, persistent venous outflow obstruction may lead to post-thrombotic syndrome, characterized by chronic, persistent pain, edema, and ulceration of the affected limb. Clinical manifestations of DVT are often absent. If a symptom is present, it is typically pain. Other signs of DVT include unilateral leg swelling, dilation of superficial veins, calf tenderness, and skin that is mottled and cyanotic. Because DVT is usually asymptomatic and difficult to detect clinically, prevention of DVT is a high priority. Prevention strategies are dependent upon the condition of the individual and prior history of DVT. In general, individuals should be mobilized as soon as possible after illness, injury, or surgery. Additional prophylactic treatment for individuals at low risk can include aspirin or pneumatic devices. People at higher risk are treated prophylactically with low molecular weight heparin, or in some cases, direct thrombin inhibitors. Diagnosis is made by combining measurements of serum D-dimer concentration plus lower extremity compression Doppler ultrasonography. D-dimer is an indirect measure of the presence of thrombosis that is very sensitive but is not specific. If the D-dimer is negative, DVT is ruled out. If it is positive, The diagnosis must be confirmed with ultrasonography. Because of its high rate of sensitivity and specificity, use of a digital photoplethysmography is becoming more widespread. Management of DVTs is based on the risk of extension of the clot or embolization. For low-risk individuals, serial imaging of the deep veins may be indicated. For individuals at high risk for clot extension or pulmonary embolism, anticoagulation with low molecular weight heparin is indicated. Other options include direct thrombin inhibitors, such as fondaparinux, apixaban, argatroban, or dabigatran. Catheter-directed thrombolytic therapy may be used to dissolve the clot more quickly and reduce the risk of post-phlebitic syndrome, especially when a large clot is located in a proximal vein. However, bleeding risk is increased and many people have contraindications to the use of thrombolytics. Pharmacomechanical treatment involves catheter-directed thrombolysis in combination with catheter-mediated removal of clots and can be used in selected individuals. DVT has a high reoccurrence rate after discontinuation of anticoagulant therapy, and people with proximal DVT or pulmonary emboli, at least 3 months of therapy is indicated. Recent updated guidelines suggest that for long-term therapy of individuals with DVT without underlying cancer, direct thrombin inhibitors are recommended. For those with DVT and cancer, continued low molecular weight heparin is indicated. If the individual is active and no identifiable underlying condition is discovered, aspirin therapy alone may be indicated. So what is the superior vena cava syndrome? It is a clinical manifestation of progressive compression of the superior vena cava, or SVC, that leads to venous distension in the upper extremities and head. The leading causes of SVCS are non-small cell lung cancer, small cell lung cancer, and lymphoma. Non-malignant causes of SVCS include thrombosis, infection, such as tuberculosis and histoplasmosis, mediastinal fibrosis, cystic fibrosis, and retrosternal goiter. Pacemaker virus, central venous catheters, and pulmonary artery catheters also can lead to superior vena cava syndrome. The superior vena cava is a thin-walled and relatively low-pressure vessel that lies in a closed thoracic compartment. Therefore, tissue expansion can easily compress the SVC. The right mainstem bronchus abuts the SVC so that cancers occurring in the bronchus may press on the vessel and obstruct venous return to the right atrium. Additionally, the superior vena cava is surrounded by lymph nodes and lymph chains that commonly become involved in infection and thoracic cancers. If the onset of the superior vena cava syndrome is slow, surrounding collateral vessels may enlarge in response to the increased pressure, and symptoms may occur more gradually. The most common clinical manifestation of superior vena cava syndrome include edema and venous distension in the face, neck, trunk, and upper extremities. More rarely, cyanosis may be observed. Individuals may complain of dyspnea, dysphagia, hoarseness, stridor, cough, and chest pain. Central nervous system, the CNS edema may cause malaise, headache, visual disturbances, vertigo, awareness or memory disorders, and impaired consciousness. The skin of the face and arms may become purple and taut, and the capillary refill time may be prolonged. Respiratory distress may be present because of the edema of bronchial structures or compression of the bronchus by the carcinoma. Diagnosis is made via chest X-ray, Doppler ultrasound studies, and CTs, and contrast-enhanced MRIs. If laryngeal constriction or cerebral edema is present, emergency intervention may be required to address the underlying cause of superior vena cava syndrome. Similarly, if a rapidly growing malignancy is found, immediate treatment is indicated, including radiation or chemotherapy. With a slow-growing malignancy, stenting of the superior vena cava may be considered for immediate symptom relief, followed by the appropriate chemotherapy. For an infectious cause of superior vena cava syndrome, antibiotics are used. Fluid restriction, diuretics, supplemental oxygen, and the elevation of head also can provide symptomatic relief. Which leads us to the diseases of arteries. Hypertension. Hypertension is consistent elevation of systemic arterial blood pressure. Hypertension was defined in 2014 as a sustained systolic blood pressure of 140 milligrams of mercury or greater, or a diastolic blood pressure of 90 milligrams of mercury or greater. In 2017, hypertension was redefined as a systolic blood pressure of 130 or greater, and a diastolic blood pressure of 80 or greater. Hypertension is the most common primary diagnosis in the United States. Approximately 1 in 3 adults older than 20 years of age has hypertension. This increased to nearly 2 in 3 in those older than the age of 60. In individuals younger than the age of 45, the prevalence of hypertension is higher in men than in women. From ages 45 to 65, prevalence is the same in men and women, and after the age of 65, the prevalence of hypertension is greater in women than in men. The prevalence of hypertension is higher in blacks and in those with diabetes. Those who fall into the prehypertensive category includes between 25 and 37% of the US population, are at risk for developing hypertension unless lifestyle modification and treatment is instituted. Some individuals have isolated systolic hypertension. Isolated systolic hypertension is elevated systolic blood pressure accompanied by normal diastolic blood pressure, less than 90 milligrams of mercury. Isolated systolic hypertension is becoming more prevalent in all age groups and is strongly associated with cardiovascular and cerebrovascular events. Approximately 95% of cases of hypertension have no known cause and therefore are diagnosed as primary hypertension, also called essential hypertension. Secondary hypertension accounts for 5% of cases and is associated with an underlying primary disorder, such as renal disease. Hypertension is a complex disorder that affects the entire cardiovascular system, and all types and stages of hypertension are associated with increased risk for target organ disease events, such as myocardial infarct, kidney disease, and stroke. Factors associated with primary hypertension. A combination of genetic and environmental factor is thought to be responsible for the development of primary hypertension. Genetic predisposition of hypertension is polygenic, including polymorphism associated with renal sodium excretion, insulin and insulin sensitivity, activity of the sympathetic nervous system, and renin-angiotensin-aldosterone system, the cell membrane sodium or calcium transport, epigenetic links between environmental factors, such as diet, exercise, and smoking, with gene expression also are being defined. Risk factors associated with primary hypertension include age, ethnicity, family history of hypertension and genetic factors, lower education, and socioeconomic status. Tobacco use, psychosocial stressors, sleep apnea, and dietary factors, including dietary fats, higher sodium intake, lower potassium intake, and excessive alcohol intake. Glucose intolerance, such as diabetes and obesity, are significant risk factors. Many of these factors also are risk factors for other cardiovascular disorders. In fact, hypertension, dyslipidemia, and glucose intolerance are often found together in a condition called metabolic syndrome. Hypertension is caused by increases in cardiac output, total peripheral resistance, or both. Cardiac output is increased by any condition that increases heart rate or stroke volume, whereas peripheral resistance is increased by any factor that increases blood viscosity or reduces vessel diameter, vasoconstriction. The many factors affecting cardiac output and peripheral resistance are described in Chapter 32. Primary hypertension is the result of a complicated interaction between genetics and the environment that increase vascular tone, increase peripheral resistance, and blood volume, thus causing sustained increases in blood pressure. Multiple pathophysiologic mechanisms mediate these effects, including the sympathetic nervous system, the RAAS, the natriuretic peptides, inflammation, endothelial dysfunction, obesity-related hormones, and insulin resistance also contribute to both increased peripheral resistance and increased blood volume. Increased vascular volume is related to a decrease in renal excretion of salt, often referred to as a shift in the pressure-natriuresis relationship. This means that for a given blood pressure, individuals with hypertension tend to secrete less salt in their urine. The pathophysiology of primary hypertension can be summarized in Figure 33.3. Looking at Figure 33.3, genetics plus our environment could include obesity, adipokinanes, insulin resistance, inflammation, and dysfunction in the sympathetic nervous system, the RAA, and natriuretic hormones. These trigger vasoconstriction, renal salt and water retention, which leads to an increased peripheral resistance and increased blood volume. Due to those, we now have sustained hypertension, which can cause vascular remodeling, a hyaline sclerosis and atherosclerosis, but also can trigger a neurologic disease such as stroke, dementia, and encephalopathy, cardiac diseases, renal diseases, and retinal changes. The sympathetic nervous system contributes to the pathogenesis of hypertension in many people. In the healthy individual, the sympathetic nervous system contributes to the maintenance of adequate blood pressure and tissue perfusion by promoting cardiac contractility and heart rate, maintenance of adequate cardiac output, and by inducing arteriolar vasoconstriction, maintenance of adequate peripheral resistance. In individuals with hypertension, overactivity of the sympathetic nervous system can result from increased production of catecholamines, epinephrine and norepinephrine, or from increased receptor reactivity involving these neurotransmitters. Increased sympathetic nervous system activity causes increased heart rate and systemic vasoconstriction, thus raising the blood pressure. Efferent sympathetic outflow stimulates renin release, increases tubular sodium reabsorption, and reduces renal blood flow. Additional mechanisms of the sympathetic nervous system induced hypertension include structural changes in blood vessels, such as vascular remodeling, insulin resistance, increased renin and angiotensin levels, and a procoagulant effect. The SNS is implicated in the cardiovascular and renal complication of hypertension. Beta-blocking medications oppose the effect of the SNS and have been used for decades in the treatment of hypertension. However, because of their side effects, these medications are no longer considered first-line treatment. The role of the SNS in the pathogenesis of cardiovascular disease is summarized here in figure 33.4. Increases in the sympathetic nervous system activity means there is an increased heart rate and peripheral resistance, an increased insulin resistance, vascular remodeling, and procoagulant effects. The vascular remodeling and procoagulant effects can cause a narrowing of the vessels and vasospasms. The increase in resistance or insulin resistance can cause endothelial dysfunction, which also can trigger a narrowing of vessels and vasospasms. The increase in heart rate and peripheral resistance will trigger hypertension, whereas the narrowing in the narrowing of vessels and vasospasms can trigger hypertension. So all of them will work towards hypertension. In the healthy individual, the RAAS provides an important homeostatic mechanism for maintaining adequate blood pressure and therefore tissue perfusion. In hypertensive individuals, overactivity of the RAAS contributes to salt and water retention and increased vascular resistance. In the brain, angiotensin and angiotensin II enhances sympathetic neural outflow and alters the release of hormones that contribute to endothelial dysfunction. Insulin resistance, dyslipidemia, and platelet aggregation. Further, angiotensin II mediators arteriolar remodeling, which is a structural change in the vessel wall that results in a permanent increase in peripheral resistance. Angiotensin II is associated with end organ effects of hypertension, including atherosclerosis, renal disease, and cardiac hypertrophy. Finally, aldosterone not only contributes to sodium retention by the kidneys, but also has other deleterious effects on the cardiovascular system. Medications such as angiotensin converting enzymes, such as ACE inhibitors, and angiotensin receptor blockers, or ARBs, oppose the activity of the renin-angiotensin system and are effective in reducing blood pressure and protecting against target organ damage, including the synthesis of angiotensin III and IV, which also are hypothesized to contribute to hypertension. Another renin-angiotensin system has been identified that is proposed to be protective. This system uses ACE2 to create angiotensin, or Ang1 through 7, which reduces the blood pressure and has cardiovascular protective effects. Its discovery may lead to a new and more effective medication. Other RAAS pathways also can be described. The renin-angiotensin-aldosterone system and cardiovascular disease. So here we can take a look at the bradykinin that goes through the lungs, which is our ACE. This can turn into angiotensin II, angiotensin III, and angiotensin IV. Then we have our liver that releases angiotensinogen, or which converts to Ang1. That then goes into an ACE, which then turns to angiotensin II, III, and IV. And then we also have the renin system from the kidneys that I believe work together with the angiotensinogen to create angiotensin I. So our receptors can come from the brain, the heart, the adrenal gland, the kidneys, and efferent arterioles. But angiotensin II can cause an increase in endothelial dysfunction, decrease apoptosis, increase growth hormone or growth, can increase smooth muscle cell growth and migration, increase platelet aggregation, and therefore increase thrombosis. Populations with high dietary sodium intake have long been shown to have an increased incidence of hypertension. Low levels of dietary potassium, calcium, and magnesium are also are risk factors because sodium is retained without their intake. The natriuretic hormone modulate renal sodium excretion and require adequate potassium, calcium, and magnesium to function properly. The natriuretic hormones include atrial natriuretic peptide, B-type natriuretic peptide or BNP, and C-type natriuretic peptide, and urodilatin. These hormones induce diuresis, enhancement of renal blood flow and glomerular filtration rate, systemic vasodilation, and suppression of aldosterone, and inhibition of the central nervous system. Dysfunction of these hormones, along with alterations in the renin-angiotensin-aldosterone system and the sympathetic nervous system, cause an increase in vascular tone and a shift in the pressure-natriuresis relationship. When there is inadequate natriuretic function, serum levels of the natriuretic peptides rise in an attempt to compensate. In hypertension, increased ANP and BNP levels are compensated. Sorry, that's incorrect. In hypertension, increased ANP and BNP levels are linked to an increased risk for ventricular hypertrophy, atherosclerosis, and heart failure. Salt retention leads to water retention and increased blood volume, which contributes to an increase in blood pressure. Subtle renal injury results with renal vasoconstriction and tissue ischemia. Tissue ischemia causes inflammation of the kidneys and contributes to dysfunction of the glomeruli and tubules and promote additional sodium retention. Increasing dietary intake of potassium, calcium, and magnesium can enhance natriuretic peptide function. New natriuretic peptide agonists are being studied. Inflammation also plays a role in vascular dysfunction of hypertension. Endothelial injury and tissue ischemia result in the release of vasoactive inflammatory cytokines. Although many of these cytokines, histamine and prostaglandins, have vasodilatory action in acute inflammatory injury, chronic inflammation contributes to the vascular remodeling and smooth muscle contraction. Endothelial injury and dysfunction in primary hypertension are further characterized by decreased production of vasodilators, such as nitric oxide, and increased production of vasoconstrictors, such as endothelium. Obesity is recognized as an important risk factor for hypertension in both adults and children, and contribute to many of the neurohormonal, metabolic, renal, and cardiovascular processes that cause hypertension. Obesity causes changes in what are called the adipokines, leptin, resistin, and adiponectin, and is associated with increased activity in the sympathetic nervous system and the renin-angiotensin-aldosterone system. Obesity is linked to inflammation, small artery remodeling, endothelial dysfunction, insulin resistance, and increased risk for cardiovascular complications from hypertension. The association between obesity and hypertension begins in adolescence and can have lifelong effects on health. Finally, insulin resistance is common in hypertension, even in individuals without clinical diabetes. Insulin resistance is associated with endothelial injury and affects renal function, causing renal salt and water retention. Insulin resistance is associated with overactivity in the sympathetic nervous system and the renin-angiotensin-aldosterone system. It is interesting to note that in many individuals with diabetes treated with drugs that increase insulin sensitivity, blood pressure often declines, even in the absence of antihypertensive drugs. The interaction between obesity and hypertension, insulin resistance, and lipid disorder in the metabolic syndrome result in a high risk of cardiovascular disease. It is likely that primary hypertension is an interaction between many of these factors, leading to sustained increases in blood volume and peripheral resistance. The role of these mechanisms in increasing blood volume in the pathophysiology of primary hypertension is summarized here in Figure 33.6. So there are many different things that decrease renal salt excretion, which shift pressure and natriuresis in the relationship. So we have the big ones, the increase in SNS, genetics, decreased dietary potassium, magnesium, and calcium, increased dietary sodium intake, insulin resistance, obesity, renal glomerular and tubular inflammation, a dysfunction of the natriuretic hormones, the endothelial dysfunction, and lastly, the increase in the renin-angiotensin and aldosterone system, leading us to secondary hypertension. Secondary hypertension is caused by an underlying disease process and raises peripheral vascular resistance or cardiac output. Examples include renal vascular and parenchymal disease, adrenocortical tumors, adrenomedullary tumors, and drugs, oral contraceptives, corticosteroids, antihistamines. Blood pressure returns to normal if the cause is identified and removed before permanent structural changes can occur. This leads us to complicated hypertension. Complicated hypertension is a chronic hypertension that damages the walls of the systemic blood vessels within the walls of arteries and arterioles. Smooth muscle cells undergo hypertrophy and hyperplasia with associated fibrosis of the tunica intima and media in the process called vascular remodeling. Endothelial dysfunction, angiotensin II, catecholamines, insulin resistance, and inflammation contribute to this process. Once significant fibrosis has occurred, reduced blood flow and dysfunction of the organ perfused by these affected vessels are inevitable. Target organs include the kidneys, brain, heart, your extremities, and eyes. Cardiovascular complications include angina, pectoris. Sorry, I'm misreading this. Cardiovascular complications include angina pectoris, left ventricular hypertrophy leading to CHF, left heart failure, congestive heart failure, coronary heart disease or CAD, myocardial infarcts, and sudden death. Myocardial hypertrophy is mediated by several neurohormonal substances, including the SNS and angiotensin II. Hypertrophy is characterized by changes in the myocyte proteins, apoptosis of the myocytes, and deposition or deposition of collagen in heart muscle, which causes it to become thickened, scarred, and less able to relax during diastole, leading to heart failure with preserved ejection fraction. In addition, the increased size of the heart muscle increases demand for oxygen delivery over time. Contractility of the heart is impaired, and the individual is at increased risk for systolic heart failure. Vascular complications include the formation, dissection, and rupture of aneurysms, outpouchings in vessel walls, intermittent claudication, and gangrene resulting from vessel occlusion. Renal complications are parenchymal damage, nephrosclerosis, renal arterial sclerosis, and renal insufficiency or failure. Microalbuminuria, or small amounts of protein in the urine, is an early sign of impending renal dysfunction and significantly increased risk for cardiovascular events. Changes in the vascular beds can be estimated by viewing the arterioles of the retina. Complications specific to the retina include retinal vascular sclerosis, exudation, and hemorrhage. Cerebrovascular complications are similar to those of other arterial beds and include transient ischemia, stroke, cerebral thrombosis, aneurysm, and hemorrhage. Chronic hypertension also has been linked to cognitive decline with aging. Hypertensive crisis or malignant hypertension is rapidly progressive hypertension in which diastolic pressure is usually greater than 140 milligrams of mercury. It can occur as an uncommon complication of primary hypertension. Other causes include complications of pregnancy, cocaine or amphetamine use, reaction to certain medications, adrenal tumors, and alcohol withdrawal. High arterial pressure renders the cerebral arterioles incapable of regulating blood flow to the cerebral capillary beds. High hydrostatic pressure in the capillaries cause vascular fluid to exude into the interstitial space. If blood pressure is not reduced, cerebral edema and cerebral dysfunction, or encephalopathy, increase until death occurs. Besides encephalopathy, hypertensive crisis can cause papilledema, cardiac failure, uremia, retinopathy, and cerebrovascular accident, and is considered a medical emergency. Treatment must be initiated rapidly to avoid serious complications. Its clinical manifestations. The early stages of hypertension have no clinical manifestations other than elevated blood pressure. For this reason, hypertension is called a silent disease. Some hypertensive individuals never have signs, symptoms, or complications, where others become very ill, and hypertension can be the cause of death. Still, other individuals have anatomic and physiologic damage caused by past hypertensive disease, despite current blood pressure measurements being within normal ranges. If elevated blood pressure is not detected and treated, it becomes established, setting the stage for the complication of hypertension that begin to appear during the fourth, fifth, and sixth decade of life. Most clinical manifestations of hypertensive disease are caused by complications affecting the target organs. Evidence of heart disease, renal insufficiency, central nervous system dysfunction, impaired vision, impaired mobility, vascular occlusion, or edema can all be caused by sustained hypertension. Our evaluation and treatment. A single elevated blood pressure reading does not mean that a person has hypertension. Diagnosis requires the measurement of blood pressure on at least 2 separate occasions, averaging 2 readings at least 2 minutes apart, with the individual seated, the arms supported at heart level, after 5-minute rest, with no smoking or caffeine intake in the past 30 minutes. Some individuals benefit from 24-hour ambulatory blood pressure monitoring because of better correlation with end organ damage and the ability to screen out white coat hypertension, which is an elevated blood pressure that occurs only in the clinical setting, and masked hypertension, normal blood pressure in the clinical setting but elevated elsewhere. Ambulatory measurements also detect those who feel to have a nocturnal decrease in blood pressure and who may be at higher cardiovascular risk. It is especially recommended for the individual with drug resistance, hypertensive symptoms with medications, episodic hypertension, and autonomic dysfunction. Evaluation of the hypertensive individual should include complete medical history and assessment of lifestyle and other risk factors for hypertension and cardiovascular disease, as well as evidence of possible secondary causes of hypertension. Physical examination should include examination of the optic fundi, calculation of body mass index, auscultation for carotid abdominal and femoral bruit, examination of the heart and lungs, palpation of the abdomen, assessment of lower extremity pulses and edema, and neurologic examination. Diagnostic tests include complete blood count, urinalysis, biochemical blood profile, measure levels of plasma glucose, sodium, potassium, calcium, magnesium, creatinine, cholesterol, and triglycerides, and an electrocardiogram, an EKG. Individuals who have elevated blood pressure are assumed to have primary hypertension unless their history, physical examination, or initial diagnostic screening indicates secondary hypertension. Once the diagnosis is made, a careful evaluation for other cardiovascular risk factors and for target organ damage should be done. Treatment of primary hypertension depends on severity. Figure 33.8 illustrates an overview of the 2017 recommendations. Treatment begins with reducing or eliminating risk factors. Lifestyle modification can prevent hypertension from developing in those individuals who fall into the elevated category. May control the blood pressure in stage 1 hypertension and can enhance these effects of drug treatment for those with more significant blood pressure elevation. Dietary modifications, such as a dietary approach to stop hypertension, diet are recommended. Physical training increases stroke volume, which has the effect of lowering heart rate and hence systolic blood pressure, and should consist of regular aerobic physical activity. Individuals are counseled to stop smoking to eliminate vasoconstrictor effects of nicotine. So here we're looking at some of the recommendations for treatment and follow-up. Leave that here for just a moment. The pharmacologic treatment of hypertension reduces the risk of end organ damage and prevents major diseases such as myocardial ischemia and stroke. Recent recommendations describe specific targets, blood pressure outcomes, and medication choices for individuals based on age, ethnicity, and comorbidities, such as diabetes and renal disease. Common recommended medications include thiazide diuretics, ACE inhibitors or ARBs, calcium channel blockers. Additional considerations are necessary for those with coronary artery disease. Some individuals require 2 or more drugs for blood pressure control. Treatment of hypertension with a systolic blood pressure treatment goal of less than 130 milligrams of mercury is recommended for non-institutionalized ambulatory community-dwelling adults, ages 65 years and older of age, with an average systolic blood pressure of 130 milligrams of mercury or higher. For older adults, 65 years of age, with hypertension and a high burden of comorbidity and limited life expectancy, clinical judgment, patient preference, and team-based approach to assess the risk-benefit is reasonable for decisions regarding intensity of blood pressure lowering and choice of antihypertensive drugs. Attempts to treat hypertension with techniques such as renal denervation have not been consistently successful to date. However, the use of invasive procedures for resistant hypertension continues to be explored. Many new approaches to the treatment of hypertension are being explored that address the complex neurohumoral interaction that contribute to the disease, and pharmacogenetic research is leading to more personalized treatment regimes. Nutrition is significant for influencing the risk for cardiovascular disease and other chronic diseases, leading us to postural orthostatic hypotension. The term orthostatic hypotension refers to a decrease in systolic blood pressure of at least 20 milligrams of mercury or a decrease in diastolic blood pressure of at least 10 milligrams of mercury within 3 minutes of moving from a standing position. Primary orthostatic hypotension is often called neurogenic and is usually a result of neurologic disorders that affect autonomic function. Compensatory changes during standing normally increase sympathetic activity mediated through the stretch receptors, or baroreceptors, in the carotid sinus and the aortic arch. This reflex response to shifts in volume caused by postural changes leads to a prompt increase in heart rate and constriction of the systemic arterioles, which maintains a stable blood pressure. These compensatory mechanisms are not effective in maintaining a stable blood pressure in individuals with orthostatic hypotension. Primary orthostatic hypotension is often chronic. Older adults are susceptible to this type of orthostatic hypotension because of slowing of postural reflexes as part of the aging process. It also occurs in neurologic diseases such as Parkinson's disease, multiple systems atrophy, and inherited neurologic disorders. Multiple systems atrophy is a severe form of chronic autonomic failure in which there are multiple central nervous system degenerative changes, and Parkinson's disease. Individuals with this disorder also may exhibit supine hypertension, altered drug sensitivity, hyperresponsiveness of blood pressure to hyperventilation, sleep apnea, and other neurologic disturbances. Primary orthostatic hypertension is a significant risk factor for falls and associated injury. It is also associated with an increased risk of death, coronary artery disease, heart failure, and stroke. Secondary orthostatic hypotension is often acute and associated with altered body chemistry, drug action, antihypertensive or antidepressant, prolonged immobility caused by illness, starvation, physical exhaustion, any condition that produces volume depletion, such as massive diuresis, potassium or sodium depletion, or any condition that results in venous pooling, such as pregnancy, extensive varicosities of the lower extremities. Other more chronic forms of secondary orthostatic hypotension are seen with adrenal insufficiencies, diabetes mellitus, cardiovascular disease, and a paraneoplastic syndrome. Orthostatic hypotension is often accompanied by dizziness, blurring or loss of vision, syncope, and correlation with symptoms. 24-hour blood pressure monitoring is recommended. Basic diagnostic tests include EKG and blood electrolyte measurements. Other tests in selected individuals may include autonomic testing, serum catecholamine measurements, and heart rate variable testing. Treatment for secondary OH is focused on correcting the underlying disorder. No curative treatment is available for primary orthostatic hypertension. Management includes liberalizing salt intake, raising the head of the bed, wearing thigh-high stockings, and administering erythropoietin, somatostatin, volume expansion with mineralocorticoids, and vasoconstrictors, such as midodrine and pyridostigmine. Aneurysm. An aneurysm is a localized dilation or outpouching of a vessel wall or cardiac chamber. Laplace's law can provide an understanding of the hemodynamic or hemodynamics of an aneurysm. True aneurysms involve all three layers of the arterial wall and are best described as a weakening of the vessel wall. Most are fusiform or circumferential. A false aneurysm is an extravascular hematoma that communicates with the intravascular space. A common cause of this type of lesion is a leak between the vascular graft and a natural artery. Aneurysms most commonly occur in the thoracic or abdominal aorta. The aorta is particularly susceptible to aneurysm formation because of constant stress on the vessel wall and the absence of penetrating vasa vasorum in the medial layer. Chronic inflammation of the wall of the aorta causes weakening of the intima and medial layers. Arterial sclerosis and hypertension are found in more than half of all individuals with aneurysms. Chronic hypertension results in mechanical and shear forces that contribute to remodeling and weakening of the vessel wall. Atherosclerosis is a common cause of aneurysms because plaque formation erodes the vessel wall. From studies of abdominal aortic aneurysm, the main pathologic features include extracellular matrix remodeling, loss of vascular smooth muscle cells, and accumulation of inflammatory cells. The inflammatory process has a critical role in abdominal aortic aneurysm, influencing aortic wall remodeling, possibly as a result of distinct subsets of monocytes and macrophages. Infections, such as syphilis, and collagen disorders such as the Marfan syndrome, and traumatic injury to the chest or abdomen also can cause aortic aneurysms. Genetic susceptibilities have been identified, including gene polymorphism for the production of growth factors, myosin, and proteases, inflammation with the production of toxic oxygen radicals, and changes in cytokines, such as the tumor growth factor hormone B or beta, activate matrix degrading proteins and smooth muscle cell apoptosis, resulting in loss of medial elastic laminae and thinning of the tunica media. Formation of a ventricular wall aneurysm most often occur when intraventricular tension stretches non-contracting infarcted muscle. The stretching produces infarct expansion, a weak and thin layer of necrotic muscle, and fibrous tissue that bulges with each systole. With time, the aneurysm becomes more fibrotic, but continues to bulge with each systole, thus acting as a reservoir and reducing stroke volume. Clinical manifestations depend on where the aneurysm is located. Aneurysms in the heart present with dysrhythmias, heart failure, and embolism of clots to the brain or other vital organs. Aortic aneurysms often are asymptomatic until they rupture, and when they become painful. Symptoms of dysphagia, or difficulty in swallowing, and dyspnea, breathlessness, are caused by the pressure of the thoracic aneurysm on surrounding organs. An abdominal aneurysm can impair flow to an extremity and cause symptoms of ischemia. Aneurysms that occur elsewhere in the body have variable symptoms and signs related to the size of the aneurysm and the potential for rupture and hemorrhage. The diagnosis of an aneurysm is usually confirmed by ultrasound or ultrasonography, CT, MRI, and angiography. The goals of medical treatment of aneurysms are to maintain a low blood volume and low blood pressure to decrease mechanical forces, thought to contribute to vessel wall dilation. Medical treatment is indicated for slow-growing aortic aneurysms, particularly in early stages, and includes smoking cessation, reducing blood pressure and blood volume, and administering beta-adrenergic blockage medications. Aortic aneurysms can be complicated by the acute aortic syndromes that include vessels rupture and aortic dissection. Rapidly expanding aneurysms are prone to rupture, and urgent surgical treatment often is indicated. New endovascular surgical techniques, with placement of a stent, make aneurysm repair possible even in those individuals with acute symptoms or complications. Aortic dissection is a devastating complication that can involve any part of the aorta. Dissection of the ascending aorta is called type A, and in any other part of the aorta it is called type B. Dissection can disrupt flow through arterial branches, thus creating a surgical emergency. The risk is increased in individuals with hypertension, congenital heart disorders, atherosclerosis, and Marfan syndrome. Dissection of the layers of the arterial wall occurs when there is inflammation, a release of enzymes that damage the vessel wall, followed by a tear in the intima and blood vessel that enters the wall of the arteries, or blood that enters the wall of the arteries. Individuals with acute aortic dissection complain of severe pain in the neck, jaw, chest, back, or abdomen, and diagnosis is made emergently with CT echocardiography or MRI. Although medical therapy may be indicated for a type B dissection, type A is considered an emergency, needing immediate surgical intervention. Arterial thrombus formation. As in venous thrombosis, arterial thrombi tend to develop wherever intravascular conditions promote activation of the coagulation or clotting cascade. In the arteries, activation of the coagulation cascade is most often caused by roughening of the tunica intima by atherosclerosis. Another important cause is anatomic changes of an artery, such as an aneurysm, that can stimulate thrombus formation, particularly if the change results in the pooling of arterial blood. Thrombi also form on heart valves, altered by calcification or bacterial vegetation. Valvular thrombi are associated most commonly with inflammation of the endocardium or endocarditis and rheumatic heart disease. Widespread arterial thrombus formation can occur in shock, particularly shock resulting from septicemia. In septic shock, systemic inflammation activates the intrinsic and extrinsic pathways of coagulation, resulting in microvascular thrombosis throughout the systemic arterial circulation. Arterial thrombi pose two potential threats in the circulation. First, the thrombus may grow large enough to occlude the artery, causing ischemia in tissue supplied by the artery. Second, the thrombus may dislodge, becoming a thromboembolism or thromboembolus that travels through the vascular system until it occludes flow into the distal systemic vascular bed. Diagnosis of arterial thrombi is usually accomplished through the use of a Doppler ultrasonography or angiography. Pharmacologic treatment involves the administration of heparin, warfarin derivatives, thrombin inhibitors, or thrombolytics. A balloon-tipped catheter also can be used to remove or compress an arterial thrombus. Various combinations of drug and catheter therapies are sometimes used concurrently. So what is an embolism? It is the obstruction of a vessel by an embolus, a bolus of matter that is circulating in the bloodstream. The embolus may consist of a dislodged thrombus, an air bubble, an aggregate of amniotic fluid, an aggregate of fat, bacteria, cancer cells, or foreign substances. An embolus travels in the bloodstream until it reaches a vessel through which it cannot fit. No matter how tiny it is, an embolism eventually will lodge in a systemic or pulmonary vessel. The source of the embolus determines whether the embolus will lodge in a vessel of the pulmonary or systemic circulation. Embolism can cause ischemia or infarction in tissue distal to the obstruction. A limb that is ischemic because of an arterial occlusion is characterized by an almost waxy whiteness of the skin, because the vasculature is devoid of erythrocytes, and by numbness and pain resulting from neural ischemia. Embolism to a central organ causes organ dysfunction and pain, and can be life-threatening. For example, pulmonary artery embolism causes chest pain and dyspnea. Renal artery embolism causes abdominal pain and oliguria, and mesenteric artery embolism causes abdominal pain and a paralytic ischemic bowel. Embolism to a coronary or cerebral artery can result in a heart attack or stroke. So thromboembolism is a vascular obstruction resulting from a dislodged thrombus. Pulmonary emboli originate in the venous circulation, mostly from the deep veins of the legs or in the right heart. Arterial emboli most commonly originate from the thrombi in the left heart that form as a result of a heart attack. Valvular disease, left heart failure, endocarditis, and dysrhythmias. More than half of these thromboemboli lodge in the lower extremities, in the femoral or popliteal arteries. Others lodge in the coronary arteries and the cerebral vasculature. An air embolism. Room air that enters the circulation through intravenous lines is a common cause of air embolism. Air also can be introduced into the bloodstream if trauma to the chest causes air from the lungs to enter the vascular space. For example, gunshot wounds or puncture wounds of the thorax sometimes introduces air emboli. Room is about 70% nitrogen. Although nitrogen dissolves quickly in blood, large amounts of air cannot be dissolved rapidly enough to prevent the displacement of blood in the arterioles and capillary beds. Ischemia and necrosis occur when air totally blocks the vessel. Treatment for air emboli is supportive, including bed rest and supplemental oxygen, once the connection between the source of the air and the vascular system is eliminated. An amniotic fluid embolism. The great intra-abdominal pressure generated during labor and delivery may force amniotic fluid into the mother's bloodstream through the highly vascular uterine wall. Amniotic fluid not only displaces blood, reducing oxygen, nutrient, and waste exchange, but also introduces antigen cells. Antigens, cells, and proteins, aggregates that trigger inflammation, coagulation, and the immune response within the bloodstream. Capillary beds usually are affected by amniotic fluid emboli, especially the capillary beds of the lungs and kidneys. Treatment is supportive and may include dialysis, particularly after a cesarean delivery or hysterectomy. Bacterial embolism. Isolated bacteria in the bloodstream do not cause embolism, but aggregates of bacteria may be large enough to do so. The most common cause of bacterial embolism is infectious endocarditis, during which clumps of bacterial vegetation are dislodged from infected cardiac valves and ejected into the pulmonary or systemic circulation. A less common cause is erosion of the artery or vein by bacteria at a source of infection, such as an abscess. Treatment for bacterial embolism include bed rest, supplemental oxygen, and antibiotics to eradicate the source of infection. Fat embolism. Trauma to the long bones is associated with a fat embolism, particularly to the lungs. Two mechanisms have been proposed to account for the generation of fat emboli after skeletal trauma. The first is that trauma to the bones initiates defective fat metabolism, causing globules of fat to form in the blood. Platelets adhere to these globules until the conglomerate is large enough to lodge in a capillary bed. The second possible explanation is that globules of fat are released from fatty bone marrow exposed by fractures. Again, platelets adhere to the fat, globules, and embolisms occur. Treatment for fat embolism consists of prompt immobilization of fractures and supportive measures that include administration of supplemental oxygen and steroids. Steroid administration may decrease the inflammation that occurs with vascular occlusion. Inflammation in the pulmonary bed is especially dangerous because it can cause acute respiratory distress syndrome. So foreign matter can enter the bloodstream during trauma or through an intravenous or intra-arterial line. Small particles such as drug precipitates, small glass shards, or fibers from linen are sometimes introduced unintentionally into the vessel through intravenous injection or manipulation of monitoring lines. Once in the blood, these small particles initiate the coagulation cascade. The thromboemboli that form around the particles are large enough to occlude a vessel and result in ischemia. Treatment is aimed at prevention of thrombus formation around the particle, dissolution of the particle, and supportive measures to alleviate ischemia if the bolus of foreign matter is relatively large. It usually is removed surgically. Peripheral vascular disease, or thromboangiitis, obliterans, or Berger's disease, is an idiopathic autoimmune condition strongly associated with smoking that is characterized by the formation of thrombi filled with inflammatory and immune cells that disrupt the flow of the peripheral arteries. Inflammatory cytokines and toxic oxygen radicals contribute to accompanying vasospasm. Over time, these thrombi become organized and fibrotic and result in permanent occlusion and obliteration of portions of small and medium-sized arteries in the feet and sometimes in the hands. Typically affected are the digital, tibial, and plantar arteries of the feet and the digital, palmar, and ulnar arteries of the hands. The chief symptoms of thromboangiitis obliterans are pain and tenderness to the affected part. Clinical manifestations are caused by sluggish blood flow and include rubor, redness of the skin caused by dilated capillaries, and cyanosis, blueness of the skin caused by the blood that remains in the capillaries after its oxygen has diffused into the interstitium. Chronic ischemia causes the skin to thin and become shiny and the nails to become thickened and malformed. In advanced disease, ischemia can cause gangrene, which may require amputation. Diagnosis of thromboangiitis obliterans is made by identification of common features, such as age younger than 45 years, a smoking history, and evidence of peripheral ischemia, and by exclusion of other causes of arterial insufficiency. The most important part of treatment is cessation of cigarette smoking. Vasodilators are prescribed to alleviate vasospasm, and the individual receives instruction in exercises that use gravity to improve blood flow. If vasospasm persists, sympathectomy may be performed. Neurotherapies include immunomodulation, spinal cord stimulation, and bone marrow transplantation. Phenomenon and disease. The Raynaud phenomenon and Raynaud's disease are characterized by attacks of vasospasm in the small arteries and arterioles of the fingers, and less commonly the toes. Although the clinical manifestations of the phenomenon and the disease are the same, their causes differ. Raynaud's disease, or primary Raynaud's, is a primary vasospastic disorder of unknown origin. It is estimated to affect nearly 5% of the general population and is associated with female gender, family history, smoking, manual occupation, migraine, and cardiovascular disease. Blood vessels in affected individuals demonstrate endothelial dysfunction, with an imbalance between the endothelium-derived vasodilators, like nitric oxide, and vasoconstrictors, endothelin-1. Platelet activation may play a role, and vasospastic attacks triggered by brief exposure to cold or by emotional stress. Raynaud's phenomenon, or secondary Raynaud's, is secondary to systemic disease, such as collagen vascular disease, like scleroderma, chemotherapy, cocaine use, hypothyroidism, pulmonary hypertension, thoracic outlet syndrome, serum sickness, vasculitis, or malignancy. Vascular inflammation and vasospasm may reflect progression of the underlying disease. The clinical manifestation of the vasospastic attacks of either disorder are pallor, numbness, and the sensation of cold in the digits. Attacks tend to be bilateral, and manifestations usually begin at the tips of the digits and progress to the proximal phalanges. Sluggish blood flow resulting in ischemia may cause the skin to appear cyanotic. Rubor follows as vasospasms end and capillaries become engorged with oxygenated blood. Rubor often is accompanied by throbbing and paresthesia. Skin color returns to normal after the attack, but frequent prolonged attacks may cause the skin of the fingertips to thicken and the nail to become brittle. In severe chronic Raynaud's phenomenon or disease, ischemia eventually can cause ulceration and gangrene. Once evident, the clinical manifestation confirms the diagnosis of Raynaud's phenomenon. However, nail-fold capillaroscopy is a more sensitive method of diagnosing and can improve management and follow-up of individuals with associated collagen vascular disorders. The diagnostic criteria for Raynaud's disease include not only the characteristic clinical manifestations described previously, but also the absence of necrosis, no detectable underlying cause, normal digit photoplethysmography and pulse contour analysis, normal lab tests for inflammation, and negative tests for anti-nuclear factor. Treatment of Raynaud's disease consists of avoidance of stimuli that trigger attacks, emotional stress, cold, and use of arm exercises, vasodilators, and biofeedback. Treatment for Raynaud's phenomenon consists of removing the stimulus of treating the primary disease process. When Raynaud's phenomenon is associated with malignancy, surgical removal of the tumor may resolve the ischemia. For Raynaud's phenomenon not associated with malignancy, management includes arm exercises, vasodilators, sympathectomy, and botulinum toxin. That leads us to atherosclerosis, which is a form of arteriosclerosis, in which thickening and hardening of the vessel are caused by the accumulation of lipid-laden macrophages within the arterial wall, which leads to the formation of a lesion called plaque. Atherosclerosis is not a single disease, but rather a pathologic process that can affect vascular systems throughout the body. resulting in ischemic syndromes that can vary widely in their severity and clinical manifestations. It is the leading cause of coronary artery and cerebrovascular disease. Atherosclerosis of the coronary arteries is described in the coronary artery disease, and the coronary arteries is myocardial ischemia and acute coronary syndrome section. Atherosclerosis in the cerebral arteries is discussed in chapter 18, one that we will get back to. The pathophysiology. Atherosclerosis is a chronic inflammatory condition that results from the interaction of numerous pathophysiologic processes, culminating in damage to arterial walls. Pathologically, the lesions progress from endothelial injury and dysfunction to fatty streak fibrotic plaque to complicated lesions. So here we see the damaged endothelium. I might make this a little bigger just to make it a little easier to see. So you see a little tiny portion of damaged endothelium, which leads to fatty streaks to build up. That fibrous plaque then gets full of fibroblasts, and it forms a thrombus from a complicated lesion. Atherosclerosis begins with injury to the endothelial cells that line arterial walls. There are many possible causes of endothelial injury, such as aging, smoking, high blood pressure, and diabetes. The risk factors for atherosclerosis is discussed in more detail in the following section on coronary artery disease. Injured endothelial cells become inflamed and cannot make normal amounts of antithrombotic and vasodilating cytokines. The adventitia also plays an important role through production of reactive oxygen species and activation of endothelial inflammation. Low-density lipoprotein penetrates into the subintima of the arterial walls, where it is trapped by proteoglycans. Inflammation, oxidative stress, and activation of macrophages causes the aggregated low-density lipoprotein to become oxidized. Hypertension increases levels of the low-density lipoprotein, oxidative stress, and activation of the renin-angiotensin-aldosterone system all contribute to an acceleration of the step in atherogenesis. Inflammation and oxidized LDLs cause endothelial cells to express adhesion molecules that bind monocytes and other inflammatory and immune cells. Monocytes penetrate the vessel wall, becoming macrophages. Several types of receptors on these macrophages, toll-like receptors, and the LDL receptor-related protein, enable detection and engulfment of the oxidized LDL. These lipid-laden macrophages are now called foam cells, and when they accumulate in significant amounts, they form a lesion called a fatty streak, and numerous inflammatory cytokines end up releasing. Your tumor necrosis factor alpha, interferons, interleukins, and C-reactive protein, as well as enzymes that further injure the vessel wall. Growth factor also are released, including angiotensin II, fibroblast growth factor, or TGF-beta, and platelet-derived growth factor, which stimulates that smooth muscle cell proliferation in the affected vessel. These smooth muscle cells produce collagen and migrate over the fatty streak, forming a fibrous plaque. The fibrous plaque may calcify, protrude into the vessel lumen, and obstruct blood flow to the distal tissue, especially during exercise, which may cause symptoms of angina or intermittent claudication. Many plaques, however, are unstable, meaning they are prone to rupture even before they affect blood flow and are clinically silent until they rupture. Plaque ruptures occur because of the inflammatory activation of the proteinases or matrix metalloproteinases and cathepsins, apoptosis of cells within the plaque, and bleeding within the lesion or plaque hemorrhage. Plaques that have ruptured are called complicated plaques. Once ruptured, or once rupture occurs, exposure of the underlying tissue results in platelet adhesion, initiation of the clotting cascade, and a rapid thrombus formation that may suddenly occlude the affected vessel, resulting in ischemia and infarction. Aspirin and other antithrombotic agents are used to prevent this complication of atherosclerotic disease. So what kinds of clinical manifestations would we see? Well, atherosclerosis presents with symptoms and signs that result from inadequate tissue perfusion because of obstruction of the vessel walls that supply them. Partial vessel obstruction may lead to transient ischemic events, often associated with exercise or stress. Once the lesion becomes complicated, increasing obstruction with superimposed thrombosis may result in tissue infarction. Obstruction of peripheral arteries can cause significant pain and disability. CAD, caused by atherosclerosis, is a major cause of myocardial ischemia and is one of the most important health issues in the United States. Atherosclerotic obstruction of the vessels supplying the brain is the major cause of stroke. Often, more than one vessel is involved with this disease process. Consequently, an individual may present with symptoms from several ischemic tissues all at the same time, and disease in one area may indicate that the individual is at risk for ischemic complications elsewhere. So what is our evaluation and overall treatment plan? Well, in evaluating individuals for the presence of atherosclerosis, a, a complete health history, including risk factors and symptoms of ischemia, is essential. Physical examination may reveal arterial bruise and evidence of decreased blood flow to tissues. Lab testing includes measurements of your lipid panel, your blood glucose, and high-sensitivity CRPs. Judicious use of X-ray film, electrocardiography, ultrasonography, nuclear scanning, CT and MRIs, and angiography may be necessary to identify the affected vessels, particularly in coronary vessels. Prevention and atherosclerosis encompass a broad range of non-pharmacologic and pharmacologic approaches to reducing risk factors such as dyslipidemia, hypertension, diabetes, smoking, and obesity. Management of atherosclerotic risk factors for coronary artery disease is discussed further in the coronary artery disease section, myocardial ischemia, and acute coronary syndrome sections. Current management of atherosclerosis is focused on detecting and treating preclinical lesions with drugs aimed at stabilizing and reversing plaque before they rupture. Once a lesion obstructs blood flow, the primary goal in managing atherosclerosis is to restore adequate blood flow to the affected tissue. If an individual has presented with acute ischemia, interventions are specific to the diseased area and are discussed further under those topics. In situations in which the disease process does not require immediate intervention, management focuses on reducing risk factors, removing the initial causes of vessel damage, and preventing lesion progression. This includes exercise, smoke cessation, and control of hypertension and diabetes when appropriate, while reducing LDL cholesterol by diet or medication, or both. Peripheral artery disease, or PAD, refers to atherosclerotic disease of arteries that perfuses the limbs, especially the lower extremities. PAD affects 10 to 15% of those who are 60 years of age or older, and is associated with significant morbidity and mortality. Prevalence increases with age, and PAD disproportionately affects blacks. The risk factors for PAD are the same as those for atherosclerotic disease, and is especially prevalent in individuals who smoke and those with diabetes. PAD is a significant predictor of systemic atherosclerotic disease, such as those with documented PAD have nearly double the risk of coronary artery disease than those without PAD. Lower extremity ischemia resulting from arterial obstruction in PAD can be gradual or acute. In many individuals, gradually increasing obstruction to arterial blood flow to the legs caused by atherosclerosis in the iliofemoral vessels results in pain with ambulation called intermittent claudication. However, ischemia may not be painful and may go undetected for years. If a thrombus forms over the atherosclerotic lesion, perfusion can cease acutely with severe pain, loss of pulses, and skin color changes in the affected extremity. Evaluation for PAD requires a careful history and physical examination that focuses on evidence of atherosclerotic disease, ankle brachial index, and non-invasive Doppler measurements of blood flow. Treatment includes risk factor reduction, such as smoking, treatment for diabetes, hypertension, and dyslipidemia, and antiplatelet therapy. Symptomatic PAD should be managed with vasodilators in combination with antiplatelet or antithrombotic medications, aspirin, cilostazol, ticlopatine, and Plavix. Cholesterol-lowering medications and exercise rehabilitation. If acute or refractory symptoms occur, emergent percutaneous or surgical revascularization may be indicated. Newer treatments and modalities that have been explored include autologous stem cell and gene therapies. Your coronary artery disease, your myocardial ischemia, and acute coronary syndrome are all forms of pathophysiologic continuum that impairs the pumping ability of the heart by depriving the heart muscle of blood-borne oxygen and nutrients. The earliest lesions of the continuum are those of the coronary artery disease, in which atherosclerosis occludes the coronary arteries. CAD can diminish the myocardial blood supply until deprivation impairs the myocardial metabolism enough to cause ischemia, a local state in which the cells are temporarily deprived of blood supply. They remain alive but cannot function normally. Persistent ischemia or the complete occlusion of the coronary artery causes acute coronary syndrome. Infarction is an irreversible myocardial injury, constitutes the often fatal event known as heart attack. So the development of coronary artery disease, per the American Heart Association, estimates that the percentage of the US population older than the age of 20 with CAD ranges from 3.3 to 6.9%, with the lowest prevalence among Asian Americans and the highest among Native Hawaiians or other Pacific Islanders. Non-Hispanic whites and blacks have approximately the same coronary artery disease prevalence at 5.5 to 5.6%. CAD and associated myocardial infarction is the number one cause of death in both men and women, resulting in one death every minute and 20 seconds in the United States. Risk factors for coronary artery disease are the same as those for atherosclerosis and can be categorized as conventional, major, and non-traditional, novel, and modifiable versus non-modifiable. This estimated 65% of whites and 90% of blacks with CAD events may have one or more of these risk factors, and avoidable death rates are nearly twice as high among blacks as compared with whites. Conventional or major risk factors for CAD that are non-modifiable include advanced age, male gender, or women with or after menopause, a family history. Aging and menopause are associated with increased exposure to risk factors and poor endothelial healing. Family history may contribute to coronary artery disease through genetics and shared environmental exposure. Many gene polymorphisms have been associated with CAD and its risk factors. Major modifiable conventional risks include dyslipidemia, hypertension, smoking, diabetes, and obesity, and an atherogenic diet. If individuals receive appropriate preventative care, modification of these factors can significantly reduce the risk for CAD. Dyslipidemia is the link between coronary artery disease and abnormal plasma lipoprotein concentration is well documented. The term lipoprotein refers to lipids, phospholipids, cholesterol, and triglycerides bound to carrier proteins. Lipids, your cholesterol in particular, are required by most cells for the manufacture and repair of plasma membranes. Cholesterol is also a necessary component for the manufacture of such essential substances as bile acids and steroid hormones, although cholesterol can easily be obtained from dietary fat intake. Most body cells also can manufacture cholesterol. The cycle of lipid metabolism is complex. Dietary fat is packaged into particulates known as chylomicrons in the small intestine that transport exogenous lipid from the intestine to the liver and peripheral cells. Chylomicrons are the least dense of the lipoproteins and primarily contain triglyceride. Some of the other triglyceride may be removed and either stored by adipose tissue or used by muscle as an energy source. Chylomicron remnants, composed mainly of cholesterol, are taken up by the liver. A series of chemical reactions in the liver result in the production of several lipoproteins that vary in density and function. These include very low-density lipoproteins, primarily triglycerides and proteins, low-density lipoproteins, mostly cholesterol and protein, and high-density lipoprotein, mainly phospholipids and proteins. Dyslipidemia refers to abnormal concentrations of serum lipoproteins as defined by the third report of the National Cholesterol Education Program. This estimated that nearly half of the U.S. population has a form of dyslipidemia. These abnormalities are the result of a combination of genetic and dietary factors. Primarily, familial dyslipoproteinemias result from genetic defects that cause abnormalities in lipid metabolizing enzymes and abnormal cellular lipid receptors. Secondary causes of dyslipidemia include several common systemic disorders, such as diabetes, hypothyroidism, pancreatitis, and renal nephrosis, as well as the use of some medications such as certain diuretics, beta blockers, glucocorticoids, interferons, and antiretrovirals. So here's some criteria for an increased serum concentration of LDL is an indicator of coronary risk. However, the relative risk of elevated LDL depends on the presence of other risk factors, such as your age, diabetes, and chronic kidney disease. Thus, new guidelines for the American Heart Association and the American College of Cardiology focus on treating dyslipidemia in the context of other risk factors. LDL is responsible for the delivery of cholesterol to the tissues. Serum levels of LDL are normally controlled by hepatic receptors that bind LDL and limit liver synthesis of this lipoprotein. High dietary intake of cholesterol and fats, often in combination with a genetic predisposition, two accumulations of LDL in the serum. A dysfunction of the hepatic LDL receptor results in high levels of LDL in the bloodstream. LDL oxidation, migration into the vessel wall, and phagocytosis by macrophages are key steps in the pathogenesis of atherosclerosis. The term LDL actually describes several types of LDL molecules. Measurement of LDL subfractions allows for better prediction of coronary risk. For example, the low-density lipoprotein, cholesterol measurements allow for detection of the small dense LDL particles that are the most atherogenic and apolipoprotein. B. Structural protein found in both LDL and VLDL. Levels are a strong predictor of future coronary events. Lowering serum level of LDL can reduce the risk for CAD. For example, recent studies found that for every 1% reduction in LDL-C, there is a 1% reduction in coronary risk in both men and women, although the 3-hydroxy-3-methylated CoA reductase medications, your statins, continue to be used for many people with elevated LDL levels and other risk factors for CAD. New and future medication aimed at lowering LDL levels, such as the protein convertase subtilisin kexin-9 or PCSK9 inhibitors are being developed. Low levels of HDL cholesterol also are a strong indicator of coronary risk. HDL is responsible for the reverse cholesterol transport, which returns excess cholesterol from the tissues to the liver, where it binds to the hepatic receptors, including the LDL receptor, and is processed and eliminated as bile or converted to cholesterol-containing steroids. HDL can remove excess cholesterol from the arterial wall through several pathways, including mediating the efflux of cholesterol from lipid-laden macrophages, your foam cells, through the activation of adenosine triphosphate ATP binding cassette transporter proteins or ABC proteins. Additional actions of HDL include protecting LDL from oxidation, preserving endothelial function, and also promoting anti-inflammatory and antithrombotic effects. As HDL cholesterol is transported, it progresses through three subtypes of HDL: the pre-beta HDL, HDL3, and HDL2. Apolipoprotein, or APOA-I, on the pre-beta HDL binds cholesterol where it is converted to cholesterol ester creating HDL3. HDL3 then increases in size to form HDL2, which is fully loaded with cholesterol. The smaller HDL3 molecule is the most protective in preventing atherosclerosis, and research continues to explore the best approach in increasing this type of HDL. The various types of HDL exert both distinct and overlapping activities, which may be compromised by the inflammatory condition, obesity, diabetes resulting in HDL dysfunction. Drugs aimed at increasing HDL have not been effective to date, but new therapies are again being explored in regards to HDL dysfunction. Other lipoproteins associated with increased cardiovascular risk include elevated levels of serum VLDL or triglycerides and increased lipoproteins. Your triglycerides are associated with an increased risk for CAD, especially in combination with other risk factors, such as diabetes. Because of this, the measurements of non-HDL cholesterol, your LDL plus VLDL, is frequently used to assess cardiovascular risk rather than just LDL or HDL levels alone. Your lipoproteins is a genetically determined molecular complex between LDL and serum glycoprotein called apoprotein A that has been shown to be an important risk factor for coronary atherosclerosis, especially in women. Hypertension is responsible for a 2 to 3-fold increased risk of atherosclerotic cardiovascular disease, including MI. It contributes to endothelial injury, a key step in atherogenesis, and causes myocardial hypertrophy, which increases myocardial demand for coronary flow. The overactivity of the SNS and RAS commonly found in hypertension also contribute to the genesis of coronary artery disease. Drugs that block the effect of SNS and RAS to treat hypertension have many positive effects on the vasculature. Smoking in the United States, approximately 17% of adults are active cigarette smokers, and direct and passive smoking accounts for approximately 1/3 of all deaths related to CAD. Smoking has a direct effect on the endothelial cells and the generation of oxygen radicals that contribute to atherogenesis. Nicotine stimulates the release of catecholamines, epinephrine and norepinephrine, which increases heart rate and causes peripheral vascular constriction. As a result, blood pressure increases, as do cardiac workload and oxygen demand. Cigarette smoking is associated with an increase in LDL and a decrease in HDL levels, and contributes to vessel inflammation and thrombosis. The risk of CAD increases with heavy smoking and decreases when smoking is stopped. Diabetes and insulin resistance are extremely important risk factors for CAD. Insulin resistance, your insulinemia, and hyperglycemia have multiple effects on the cardiovascular system. These effects can include endothelial damage, thickening of vessel wall, increased inflammation and leukocyte adhesion, increased thrombosis, glycation of vascular proteins, and decreased production of endothelial-derived vasodilators, such as nitric oxide. Diabetes is also associated with dyslipidemia and aggressive management of this additional risk factor can significantly improve CAD risk in individuals with diabetes. Obesity and your sedentary lifestyle. It is estimated that approximately 1/3 of children and 2/3 of adults in the United States are overweight or obese, resulting in as much increased risk for CAD and stroke. An estimated 47 million US residents have a combination of obesity, dyslipidemia, and hypertension, called metabolic syndrome, which is associated with an even higher risk factor for CAD events. Obesity is caused by genetics, diet, inadequate physical exercise. Abdominal obesity, also known as android obesity, has the strongest link with increased CAD risk and is related to insulin resistance, decreased HDL levels, increased blood pressure, and inflammation. Obesity is associated with changes in the adipokines and is associated with a deposition of perivascular adipose tissue that contributes to atherogenesis. A sedentary lifestyle not only increases the risk of obesity, but also has an independent effect on increasing CAD risk. It is estimated that physical inactivity is responsible for approximately 12% of myocardial infarcts. Physical activity and weight loss offer substantial reduction in risk for CAD. There is emerging evidence that bariatric surgery procedures can provide sustained improvements in risk factors for cardiovascular disease, such as hypertension, dyslipidemia, and diabetes. Atherogenic diet. Here's what I found. A diet plays a complex role in atherogenic risk. Diets high in salt, fats, trans fats, and carbohydrates have been implicated. There are many recommendations regarding diet modification to reduce coronary risk. One of the most studied dietary patterns is the Mediterranean diet. A recent randomized controlled trial in high-risk individuals suggested that following a Mediterranean diet over a 5-year period compared with a control diet was related to a 29% lower risk for CVD, or cardiovascular disease. So what is a Mediterranean diet? It is high intake of fruits, vegetables, legumes, whole grain products, fish, unsaturated fatty acids, especially olive oil, low consumption of red meat, dairy products, and saturated fatty acids. Included in this dietary pattern is the moderate consumption of alcohol, mostly wine, consumed with meals. However, investigators from a recent Mendelian randomization study reported that the lowest risk for cardiovascular outcome were in abstainers, and that any amount of alcohol is associated with elevated blood pressure and body mass index. So, there you have it. Eat healthy. Your non-traditional risk factors or novel risk factors for CAD include increased serum markers for inflammation, ischemia, and thrombosis. Adipokines, chronic kidney disease, air pollution and ionizing radiation, medications, coronary artery calcifications, and carotid wall thickness, and microbiomes. The amount of risk conferred by the relatively newly identified factor is still being explored. So, what are our markers of inflammation, ischemia, and thrombosis? Well, of the numerous markers of inflammation that have been linked to an increase in CAD, your highly sensitive C-reactive protein, or hsCRP, has been explored in the greatest depth. hsCRP is an acute phase reactant or protein, mostly synthesized in the liver, and is an indirect measure of atherosclerotic plaque-related inflammation and plaque progression. Elevated levels of hsCRP are associated with numerous other CAD risk factors, including smoking, obesity, and diabetes. While they have been found to be an independent risk factor for coronary disease, the risk is highest when there is an associated elevation in LDL-C. Current recommendations suggest that hsCRP should be used as part of an overall cardiovascular risk assessment in selected individuals. Troponin I is a serum protein whose measurement is used as a sensitive and specific diagnostic test to help identify myocardial ischemia during acute coronary syndrome. Highly sensitive troponin I assays are used in individuals without history of CAD to assess risk for future CHD events, mortality, and heart failure. Markers of thrombosis associated with CAD include fibrinogen and protein C. Your adipokines. Adipokines are a group of hormones released from adipose cells. The two that are most studied are the adiponectin and leptin. Increased serum leptin is primarily implicated because of its contributions to the complications of obesity, hypertension, and diabetes, but it is also being implicated in autoimmunity and decreased endothelial angiogenesis. Decreased adiponectin or hypoadiponectinemia in obese individuals has been linked to a significant increase in cardiovascular risk. Anti-atherogenic effects of adiponectin include anti-inflammatory, insulin-sensitizing enhancement of nitric oxide generation, attenuation of reactive oxygen species production in endothelial cells, and a reduced vascular smooth muscle cell proliferation. A more recently described adipokine is resistin, which has been linked to inflammation of endothelial dysfunction, thrombosis, and smooth muscle cell dysfunction. Emerging evidence suggests that adipokine changes occurring in perivascular adipose cells may play a significant role in metabolic and vascular disorders. Weight loss and exercise improve adipokine levels and are correlated with improved cardiovascular risk. And new therapies, such as peroxisome proliferator activator receptors or PPAR gamma agonists, upregulation of adiponectin receptors, and direct infusion of adiponectin are being explored. Your chronic kidney disease patients are at increased risk for CAD events. The risk increases as glomerular filtration rates decline. In CKD, dyslipidemia, endothelial dysfunction, vascular calcification, elevated levels of growth factor, and toxic oxygen radicals all contribute to the atherogenesis and CAD. Air pollution and ionizing radiation are exposures that are strongly correlated with coronary risk. It is postulated that toxins and pollution contribute to macrophage activation, oxidation of LDL, autonomic imbalances, thrombosis, and inflammation of vessel walls. Ionizing radiation is most often linked to cancer risk, but there is emerging evidence that even low doses of radiation may contribute to CAD. A recent hypothesis is somatic mutations in hematopoietic cells contribute to the development of human atherosclerosis. There's also a medication increase in CAD-related ischemic events that can occur within weeks of beginning NSAID use. The likelihood of a stroke or heart attack is greatest among those with pre-existing diseases, and risk increases at higher doses with no longer duration of use. There's also evidence that NSAIDs decrease the effectiveness of aspirin and its ability to prevent clot formation. Your coronary artery calcification and carotid artery wall thickness. So coronary risk related to changes in vessel walls can be assessed using various types of vascular imaging techniques. Coronary artery calcifications, or CAC, as detected via a CT scan, or carotid intima media thickness test, or CIMT, and ultrasonography are two important imaging modalities in widespread use for determining coronary heart disease and risk. CAC is likely the most useful of the current approaches to improving risk assessment among individuals found to be at intermediate risk after formal risk assessment. The microbiome. The effects of diet and other lifestyle measurements on the microbiome and CVD risk increasingly are being explored. These effects may be mediated through the impact on other risk factors, such as diabetes and autoimmunity, or through more direct effects on microbiota function. For example, hyperhomocysteine has been linked to cardiovascular risk, yet the addition of folate, which increases the homocysteine breakdown, has not improved risk. It is now postulated that the microbiome may be an important modulator of lipid and homocysteine metabolism, as well as many other atherosclerotic risk factors. In coronary artery disease, atherosclerotic plaques that form in the coronary circulation can develop in two primary ways. Stable plaques gradually increase in size and may partially occlude the vessel lumina, thus limiting coronary flow and causing ischemia, especially during exercise. Your unstable plaques are prone to ulceration or rupture, even if there has been no significant impairment of coronary blood flow before the event. When this ulceration or rupture occurs, underlying tissue of the vessel walls are exposed, resulting in platelet adhesion and thrombus formation. Thrombus formation can suddenly cut off blood supply to the heart muscle, resulting in acute myocardial ischemia. And if the vessel obstruction cannot be reversed rapidly, ischemia will progress towards infarction. Your transient myocardial ischemia, as described previously, CAD can diminish the myocardial blood supply, causing ischemia. The process of atherosclerotic plaque progression can be gradual, which usually results in transient myocardial ischemic syndromes when demand for blood supply exceeds supply, but perfusion is restored before there is permanent damage to the heart muscle. Ischemia also can occur with coronary vasospasms. Even in the absence of atherosclerosis, transient myocardial ischemia can result in unstable angina, Prince-Middle angina, or silent ischemia. The pathophysiology includes the coronary arteries normally supply blood flow sufficient to meet the demands of the myocardium because it labors under varying workloads. Oxygen extraction from the vessels occurs with maximal efficiency. If efficient exchange does not meet myocardial oxygen needs, healthy coronary arteries are able to dilate to increase the flow of oxygenated blood to the myocardium. Narrowing of a major coronary artery by more than 50% impairs blood flow sufficiently to hamper cellular metabolism under conditions of increased myocardial demand. Myocardial ischemia develops if the supply of coronary blood cannot meet the demand of myocardium for oxygen and nutrients. Imbalances between myocardial demand and coronary blood supply can result from a number of conditions. Common causes of increased myocardial demand for blood include tachycardia, exercise, hypertension or hypertrophy, and valvular disease. Myocardial ischemia also can result from other causes of decreased blood and oxygen delivery to the myocardium, such as coronary spasm, hypotension, dysrhythmias, decreased oxygen carrying capacity of the blood, anemia, hypoxemia, and aortic valvular disease. Myocardial cells become ischemic within 10 seconds of coronary occlusion. After several minutes, the heart cells lose the ability to contract, and cardiac output decreases. Ischemia also causes conduction abnormalities that lead to the changes in the electrocardiogram and may initiate dysrhythmias. Anaerobic processes take over and lactic acid accumulates. Cardiac cells remain viable for approximately 20 minutes under ischemic conditions. If blood flow is restored, aerobic metabolism resumes, contractility is restored, and cellular repair begins. If the coronary artery occlusion persists by 20 minutes, MI occurs. So what are our clinical manifestations? Individuals with reversible myocardial ischemia present clinically in several ways. Chronic atherosclerotic coronary obstruction usually results in recurrent, predictable chest pain called stable angina. Abnormal vasospasm of coronary vessels result in unpredictable chest pain called Prince-Middle angina. Myocardial ischemia that does not cause detectable symptoms is called silent ischemia. We are going to go up here a little bit and take a quick peek at our cycle of ischemic events. So, if we're starting, it doesn't look like there is really much of a start. So then let's look at the very top. An imbalance between your coronary supply and myocardial demand could be triggered by an impaired cardiac pumping, but it can further cause a myocardial oxygen deficit. When it's less than 20 minutes, it's an ischemic attack, where if it's a greater than 20 minute, it's a myocardial infarct. let's say it is greater than 20 minutes, there is an abnormal response to electrical impulses. The lack of response to electrical There is a lack of response to electrical impulses, which could mean there is a failure to contract, which further impounds our impaired cardiac pumping, leading to heart failure. Now, if it's a greater than 20-minute myocardial infarct, there's an abnormal response to electrical impulses, which is considered a dysrhythmia, and some dysrhythmias can lead to sudden death. And the same can be said about a myocardial O2 deficiency that is less than 20 minutes. It can lead to an abnormal response to electrical impulses, trigger a dysrhythmia, and that could cause you sudden death. But it could also just have a dysrhythmia that causes impaired cardiac pumping, which continues to trigger its heart failure and imbalance between coronary supply and myocardial demand. So it's a vicious cycle through and through. Stable angina. Angina pectoris is chest pain caused by myocardial ischemia. Stable angina is caused by gradual luminal narrowing and hardening of the arterial walls so that affected vessels cannot dilate in response to increased myocardial demand associated with physical exertion or emotional stress. With rest, blood flow is restored and no necrosis of myocardial cells results. Angina pectoris is typically experienced as transient substernal chest discomfort, ranging from a sensation of heaviness or pressure to moderately severe pain. Individuals often describe this sensation by clenching a fist over the sternal border on the left side. The discomfort may be mistaken for indigestion. The pain is caused by buildup of lactic acid or abnormal stretching of the ischemic myocardium that irritates myocardial nerve fibers. These afferent sympathetic fibers enter the spinal cord from level C3 to T4, accounting for the variety of locations and radiation patterns of anginal pain. Pain may radiate to the neck, lower jaw, left arm, and left shoulder, or occasionally to the back or down the right arm. Pallor diaphoresis and dyspnea may be associated with the pain. The pain is usually relieved by the rest and nitrates. Myocardial ischemia in women may not present with typical angina. Common symptoms in women include atypical chest pain, palpitation, a sense of unease, or severe fatigue. In addition, it is estimated that half of women with stable angina do not have obstructive coronary artery disease, but rather have microvascular angina that results from vasoconstriction of small coronary arterioles deep in the myocardium. Similarly, in individuals who have autonomic nervous system dysfunction, such as the older adults or those with diabetes, angina may be mild, atypical, or even silent. Your Prinzmetal angina. Prinzmetal angina, also known as a variant angina, is a chest pain attributable to the transient ischemia of the myocardium that occurs unpredictably and almost exclusively at rest. This form of angina often occurs at night during rapid eye movement sleep and may have a cyclic pattern of occurrence. Pain is caused by vasospasm of one or more major coronary arteries, with or without associated atherosclerosis. The angina may result from decreased vagal activity, hyperactivity of the sympathetic nervous system, and decreased nitric oxide activity. Other causes include altered calcium channel function in arterial smooth muscle and endothelial dysfunction with release of inflammatory mediators such as serotonin, histamine, endothelin, or thromboxane. The level of hsCRP may be elevated in individuals with this form of angina. Prince metal angina is usually a benign condition, but can occasionally cause serious dysrhythmias, especially if treatment is withdrawn. Therefore, calcium channel blockers or long-acting nitrates, or both, should be continued, even if the clinical remission is achieved. If the spasm persists long enough, infarction or serious dysrhythmias may occur. Silent ischemia and mental stress-induced ischemia. Myocardial ischemia does not always cause angina and may be associated only with nonspecific symptoms such as fatigue, dyspnea, or feeling of unease. Some individuals only have silent ischemia, whereas episodes of silent myocardial ischemia may occur in individuals who have experienced angina. Global or regional abnormalities in left ventricular sympathetic afferent innervation have been implicated in diabetes following surgical denervation, during coronary artery bypass grafting or a CABG, or cardiac transplantation, or following ischemic local nerve injury via a myocardial infarct. There also is evidence that individuals with silent ischemia produce less lactate than those with angina. Silent ischemia also may occur in some individuals during mental stress and anger. Mental stress results in the release of catecholamines and an increase in heart rate, blood pressure, and vascular resistance, as well as electrical instability. In addition, it has been linked to increased hsCRP levels, decreased activity of vasodilators such as nitric oxide, and a hypercoagulable state that may contribute to acute ischemic events. So we have our acute mental stress. It causes a central and autonomic nervous system activity. So what is our physiologic response? Well, we have an increase in catecholamines, an increase in heart rate, and blood pressure. We have a decrease in plasma volume, an increase in coronary constriction, and an increase in platelet activity. So what does the heart do as a result? Well, it increases electrical instability, has an increase in demand, but a decrease in supply. So what are our pathologic results? Well, we can go into VFib or VTAC. We can have ischemia. We can have plaque rupture. And we can have a coronary thrombosis. So either we can have a cardiac event that leaves us with a sudden cardiac death or a myocardial infarct. And our background factors is our atherosclerosis, a prior MI, or poor left ventricular function. Evaluation and treatment. Many individuals with reversible myocardial ischemia exhibit normal physical examination between episodes. Physical examination of the individual experiencing myocardial ischemia may disclose tachycardia, extra heart sounds such as gallops or murmurs, and pulmonary congestion indicating impaired left ventricular function. The presence of xanthelasmas or small fat deposits around the eyelids or arcocinalis of the eyes, a yellow lipid ring around the cornea, may suggest dyslipidemia and possible atherosclerosis. The presence of peripheral or carotid arterial buoys suggests probable atherosclerotic disease and increases the likelihood of CAD being present. Our electrocardiography is a critical tool for diagnosing myocardial ischemia. Because many individuals have normal EKGs in the absence of pain, diagnosis may result in electrocardiography be performed during an attack of angina. Your transient ST segment depression and the T-wave inversion are characteristic signs of a subendocardial ischemia, frequently seen in angina, whereas your ST elevation, indicative of transmural ischemia, can be seen in individuals with the prinzmetal angina, but is more commonly in infarcts. The EKG also can give some indication of which coronary artery is involved. Approximately 30% of individuals with angina have non-diagnostic EKG tracings and require other diagnostic studies. So here you have a normal EKG and then some altercations associated with ischemia, such as a ST depression, the T wave inversion, and an ST segment elevation. So stress radionuclide imaging is indicated to detect ischemic changes in asymptomatic individuals with multiple risk factors for coronary disease, such as diabetes and dyslipidemia, and for older individuals who plan to start vigorous exercise. Stress testing is made more sensitive when radioisotope imaging is added to the EKG as an indicator of myocardial ischemia. Currently, the modality of choice for the diagnosis of myocardial ischemia is single photon emission computed tomography, or SPECT, which is effective at identifying ischemia and estimating risk for coronary events. Radioisotope imaging with thallium-201 and stress echocardiography are also used. Unfortunately, although all these tests are helpful in documenting coronary obstruction, they cannot detect the presence of unstable plaque, which are the cause of the majority of acute coronary syndromes. Imaging the coronary arteries for the evaluation of atherosclerotic plaque involves the use of a CAT scan with and without angiography, MRI, and intravascular ultrasound. Coronary angiography is useful in determining the anatomic extent of CAD. The procedure is expensive and carries risk. Thus, it is used primarily to evaluate the possible percutaneous coronary intervention, or PCI, or coronary arterial bypass grafting, or CABG surgery, for individuals whose non-invasive studies suggest severe disease. The primary aim of therapy for myocardial ischemia and angina are to increase delivery of oxygen by improving coronary artery blood flow and to reduce myocardial oxygen consumption. Recommendations for appropriate diet, exercise, and risk reduction strategies have been widely distributed. Coronary blood flow is improved by reversing vasoconstriction, preventing clotting, and reducing plaque growth and rupture. Myocardial oxygen consumption is reduced by manipulation of blood pressure, heart rate, contractility, and left ventricular volume. Many different classes of drugs are available to manage stable angina, including nitrates, beta-adrenergic receptor blockers, and calcium channel blockers. Statins are indicated for primary prevention in high-risk individuals and for all those with known CAD. Antithrombotics, such as aspirin or Plavix, reduce the risk of clot formation. Angiotensin-converting enzymes, or ACE inhibitors, or angiotensin II receptor blockers are indicated for all people with coronary artery disease who also have diabetes, hypertension, and or left ventricular systolic dysfunction. Ranolazine represents a relatively new class of anti-anginal drug known as sodium channel inhibitor and has been found to improve exercise tolerance, lessen anginal symptoms, and reduce the need for nitrates in many individuals with chronic stable angina. Coronary revascularization is indicated for those individuals who do not respond adequately to anti-anginal drugs or who have high-risk atherosclerotic lesions. Percutaneous coronary intervention, such as PCIs, is a procedure whereby stenotic or narrowed coronary vessels are dilated with a catheter. Several different types of catheters can be used to open blood vessels. PCI is most often used to treat single vessel disease, but it can be effective with multiple vessel disease or restenosis of the coronary artery bypass graft in selected individuals. Restenosis of the artery is a major complication of the procedure. However, placement of the coronary stent can reduce this risk, and antithrombotic treatment such as aspirin, Plavix, and glycoprotein uh, gly- oh, or glycoprotein 2B and 3A receptor antagonists after stenting can improve outcomes. Severe CAD can be surgically treated by CABG, usually using the saphenous vein from the lower leg in selected individuals, or modified CABG procedure called minimally invasive direct coronary artery bypass, or MIDCAB, can be used with much less surgical morbidity and more rapid recovery. Investigational treatment for refractory angina includes gene and stem therapies for myocardial angiogenesis and spinal cord stimulation. That makes us jump into acute coronary syndrome. When there is sudden coronary obstruction caused by thrombus formation over a rupture or ulcerated atherosclerotic plaque, acute coronary syndrome results. The acute coronary syndromes include unstable angina and myocardial infarct. Unstable angina is the result of reversible myocardial ischemia and is a harbinger of impending infarction. Myocardial infarction results when prolonged ischemia causes irreversible damage to the heart muscle. Myocardial infarction can be further subdivided into non-ST elevation MI and ST elevation MI, or STEMI. Sudden cardiac death can occur as a result of any of the acute coronary syndromes. So we'll take a quick peek here at this picture. The atherosclerotic plaque partially obstructs coronary blood flow. There could be stable plaque, which leads to stable angina. But the stable plaque can trigger unstable plaque with ulceration or rupture and thrombosis, which could have initially happened to begin with. That, however, ulceration can cause acute coronary syndromes, which triggers either a transient ischemia that leads to unstable angina. That is, same acute coronary syndrome and transient ischemia can cause sustained ischemia, which then stunned monocytes. That also triggers myocardial infarction, which causes a hibernating myocytes, and a myocardial inflammation and necrosis, which can cause the myocardial remodeling. An unstable atherosclerotic plaque is prone to rupture. It has a core that is especially rich in deposited oxidized LDL and a thin fibrous cap. These unstable plaques may not extend into the lumen of the vessel and may be clinically silent until they rupture. Plaque disruption, ulceration, or rupture occurs because of a shear force, inflammation with release of multiple inflammatory mediators, secretion of macrophage-derived degradative enzymes, and apoptosis of cells at the edges of the lesion. Exposure of the plaque substrate activities the clotting cascade. In addition, platelet activation result in the release of coagulants and exposure of platelet glycoprotein 2B and 3A. surface receptors, resulting in further platelet aggregation and adherence. The resulting thrombus can form very quickly. Vessel obstruction is further exacerbated by the release of vasoconstrictors, such as thromboxane A2 and endothelin. The thrombus may break up before permanent monocyte damage has occurred in unstable angina, or it may cause prolonged ischemia with resultant MI. Diagnostic tests aimed at identifying unstable plaques before they rupture include intravascular ultrasound or MRI, angioscopy, and spectroscopy. Medications such as statins, ACE inhibitors, and beta blockers can help stabilize plaque and prevent rupture. Your unstable angina is a form of acute coronary syndrome that results in reversible myocardial ischemia. It is important to recognize this syndrome because it signals that the atherosclerotic plaque has ruptured and infarction may soon follow. Your unstable angina occurs when fissuring or superficial erosion of the plaque leads to transient episodes of thrombotic vessel occlusion and vasoconstriction at the site of plaque damage. This thrombus is liable and occludes the vessel for no more than 10 to 20 minutes, with return of perfusion before significant myocardial necrosis can occur. Your unstable angina presents as new onset angina, angina that is occurring at rest, or angina that is increasing in severity or frequency. Individuals may experience increased dyspnea, diaphoresis, and anxiety as the angina worsens. So, our physical examination may reveal evidence of ischemic myocardial dysfunction, such as tachycardia and pulmonary congestion. An EKG most commonly reveals ST segment depression and T wave inversion during pain that resolves as the pain is relieved. The serum cardiac biomarkers, your troponins, and your creatinine phosphokinase myocardial bound CPK-MB remain normal. Management of unstable angina is the same as the management for non-STEMI and requires immediate hospitalization. Administration of nitrates, antithrombotics, aspirin, and ticagrelor, and or GP2B, 3A platelet receptor antagonists, and anticoagulants, heparin, your low molecular weight heparin, or direct thrombin inhibitors, such as your fondaparinux, is recommended. If the individual stabilizes, then continued anticoagulation plus beta blockers and ACE inhibitors are indicated. If the patient is refractory to medical treatment, then an emergent PCI is indicated. Your myocardial infarct. When coronary blood flow is interrupted for an extended period, myocyte necrosis occurs. This results in an MI. Pathologically, there are two major types: a subendocardial infarct and a transmural infarct. Clinically, however, MI is categorized as STEMI or non-STEMI. So what is our pathophysiology? Well, plaque progression, disruption, and subsequent clot formation are the same for myocardial infarct as they are for unstable angina. In this case, however, the thrombus is less labile and occludes the vessel for a prolonged period, such that myocardial ischemia progresses to myocyte necrosis and death. The duration of ischemia determines the size and character of the infarct. If the thrombus breaks up before complete distal tissue necrosis has occurred, the infarction will involve only the myocardium directly, beneath the endocardium, or subendocardial MI. This infarction usually presents with ST depression and T wave inversion and is termed non-STEMI. It is especially important to recognize this form of acute coronary syndrome because recurrent clot formation on the disrupted atherosclerotic plaque is likely to occur unless some intervention is undertaken as soon as possible. If the thrombus lodges permanently in the vessel, the infarction will extend through the myocardium all the way from endocardium to epicardium, a transmural MI, resulting in severe cardiac dysfunction. Transmural infarction usually causes marked elevation in the ST segment on EKGs called STEMI. Clinically, it is important to identify those with a STEMI because they are at the highest risk for serious complications and require immediate intervention. So here we have an endocardium, your coronary artery and thrombus, the zone of ischemic myocardium, and your pericardium. Then in section B, it shows that your coronary artery, your thrombus, and your non-ischemic or your non-STEMI and pericardium is starting to even fill out. And then lastly, you have that whole STEMI section. Cellular injury. Cardiac cells can withstand ischemic conditions for about 20 minutes before cellular death takes place. Only 30 to 60 seconds after an hypoxic event, EKG changes are visible, yet even if cells are metabolically altered and non-functional, they can remain viable if blood flow returns within 20 minutes. Reports suggest previous recurrent episodes of myocardial ischemia can result in myocyte adaptation to oxygen deprivation and preservation of myocardium. This process, termed ischemic preconditioning, results in changes in reactive oxygen species, calcium ions, adenosine, bradykinin, catecholamines, and opioids that exert protective effects on the myocardium. Therapeutic ischemic preconditioning has been used in individuals undergoing elective CABG or valvular replacement and in individuals with STEMI before emergent PCI. However, more studies are needed to determine the best use of the modality. After 8 to 10 seconds of decreased blood flow, the affected myocardium becomes cyanotic and cooler. Myocardial oxygen reserves are used very quickly, within about 8 seconds. After complete cessation of coronary flow, glycogen stores decrease as anaerobic metabolism begins. Unfortunately, glycolysis can supply only 65% to 70% of the total myocardial energy requirement and produces much less ATP than aerobic processes. Hydrogen ions and lactic acid accumulate. Because myocardial tissue have poor buffering capabilities and myocardial cells are very sensitive to low cellular pH accumulation of these products, further compromise the myocardium. Acidosis may make the myocardium more vulnerable to the damaging effects of lysosomal enzymes and may suppress impulse conduction and contractile function, thereby leading to heart failure. Oxygen deprivation also is accompanied by electrolyte disturbances, specifically loss of potassium, calcium, and magnesium from cells. Myocardial cells deprived of necessary oxygen and nutrients lose contractility, thereby diminishing the heart's pumping ability. Ischemic myocardial cells release catecholamines, your epinephrine and norepinephrine, predisposing the individual to serious imbalances of sympathetic and parasympathetic function, irregular heartbeats, and heart failure. Catecholamines mediate the release of glycogen, glucose, and stored fat from body cells. Therefore, plasma concentrations of free fatty acids and glycerol rise within 1 hour after the onset of an acute MI. Excessive levels of free fatty acids can have a harmful detergent effect on cell membranes. Norepinephrine elevates blood glucose levels through stimulation of liver and skeletal muscle cells. It also suppresses pancreatic B cells activity, which reduces insulin secretion and elevates blood glucose levels further. Angiotensin II is released during myocardial ischemia and contributes to the pathogenesis of MI in several ways. First, it results in the systemic effects of peripheral vasoconstriction and fluid retention. These homeostatic responses are counterproductive in that they increase myocardial work and thus exacerbate the effects of the loss of myocyte contractility. Angiotensin II is also released locally, where it is a growth factor for vascular smooth muscle cells, myocytes, and cardiac fibroblasts, promoting catecholamine release and coronary artery spasm. Ischemic injury can be exacerbated by what is termed reperfusion injury, once blood flow is restored. This process involves the release of toxic oxygen radicals, calcium flux, and pH changes that cause a sustained opening of mitochondrial permeability transition pores, or MPTPs, and contribute to resultant cellular death. Infiltration of inflammatory cells contribute to tissue injury. Therapies aimed at reducing reperfusion injury are being explored, including targeted temperature management, use of adenosine or atrial natriuretic peptide, and ischemic postconditioning. Cellular death. After about 20 minutes of myocardial ischemia, irreversible hypoxic injury causes cellular death and tissue necrosis. Necrosis of the myocardial tissue results in the release of intracellular enzymes, such as troponin, through the damaged cell membranes into the interstitial space. The lymphatics pick up the enzyme and transport them into the bloodstream, where they can be detected by serologic tests. Recent evidence has found that, along with necrosis, myocardial tissue is also destroyed by apoptosis and autophagy. An increased understanding of these processes in MI may lead to new therapies aimed at limiting infarct size. Your structural and functional changes. As a result of an MI, structural and functional changes occur within cardiac tissue. Gross tissue changes in the area of infarction may not become apparent for several hours, despite almost immediate onset within 30 to 60 seconds of EKG changes. The infarcted myocardium is surrounded by a zone of hypoxic injury, which may progress to necrosis, undergo remodeling or scarring, or return to normal. Myocardial stunning is a temporary loss of contractile function that persists for hours to days after perfusion has been restored. This pathophysiologic state can occur both with MI and individuals who suffer ischemic or ischemia during cardiovascular procedures, such as a cardiac surgery. Stunning is caused by the alterations in the electrolyte pumps, calcium homeostasis, and the release of toxic oxygen radicals. It is characterized by a decreased contraction and conduction and can contribute to heart failure, shock, and dysrhythmias. Hibernating myocardium refers to tissue that is persistently ischemic and undergoes metabolic adaptation to prolong myocyte survival until perfusion can be restored. Restoring adequate perfusion to the myocardium and revascularization therapies can improve myocardial function. However, future therapies aimed specifically at maintaining myocyte viability are needed. Myocardial remodeling is a process mediated by angiotensin II, aldosterone, catecholamines, adenosine, oxidative stress, and inflammatory cytokines, which causes myocyte hypertrophy, scarring, and loss of contractile function in the areas of the heart distant from the site of infarct. These changes can be limited and even reversed, reverse remodeling, through rapid restoration of coronary flow and the use of ACE inhibitors, beta blockers, statins, sequential pacemakers, and ventricular acid devices. Post-MI. Our repair. MI causes a severe inflammatory response that ends with wound repair. Repair consists of the degradation of damaged cells, proliferation of fibroblasts, and synthesis of scar tissue. Many cell types, hormones, and nutrient substrates must be available for optimal healing to proceed. Within 24 hours, leukocytes infiltrate the necrotic area, and proteolytic enzymes from scavenger neutrophils degrade necrotic tissue. A collagen matrix is deposited and is initially weak, mushy, and vulnerable to re-injury. Unfortunately, it is at this time in the recovery period that individuals feel more capable of increasing activities and thus may stress the newly formed scar tissue. After 6 weeks of necrotic area is completely replaced by scar tissue, which is strong but unable to contract and relax like healthy myocardial tissue. The severity of function impairment depends on the size of the lesion and the site of infarction. Functional changes can include a decreased cardiac contractility with abnormal wall motion, altered left ventricular compliance, decreased stroke volume, decreased ejection fraction, increased left ventricular and diastolic pressure and volume, and a sinoatrial node malfunction. Life-threatening dysrhythmias and heart failure often follow myocardial infarcts. With infarction, ventricular function is abnormal, and the ejection fraction falls, resulting in an increase in ventricular and diastolic volume. If the coronary obstruction involves the perfusion to the left ventricle, pulmonary venous congestion ensues. If the right ventricle is ischemic, increases in ischemic venous pressure occurs. Clinical manifestations. The first symptoms of acute MI is usually sudden, severe chest pain. It is not possible to distinguish between angina and MI by symptoms alone. Although the pain associated with MI tends to be more severe and prolonged, it may be described as heavy and crushing, such as an elephant sitting on my chest. Radiation to the neck, jaw, back, shoulder, or left arm is common. Some individuals experience no pain, thereby having a silent infarct. Infarction often stimulates a sensation of unrelenting indigestion. Nausea and vomiting may occur because of reflex stimulation of vomiting centers by pain fibers. Vasovagal reflexes from the area of the infarcted myocardium also may affect the gastrointestinal tract. Various cardiovascular changes are found on physical examination. The sympathetic nervous system is reflexively activated to compensate, resulting in a temporary increase in heart rate and blood pressure. Although severe myocardial damage may cause hypotension, despite elevated catecholamine activity. Abnormal extra heart sounds reflect left ventricular dysfunction. Cardiac murmurs may indicate acute valvular insufficiency. Pulmonary findings of congestion include dullness to percussion, and inspiratory crackles at the lung bases can occur if the individual develops heart failure. Peripheral vasoconstriction may cause the skin to become cool and clammy. So the evaluation and treatment. The diagnosis of acute MI is made on the basis of history, physical examination, EKG, and serial cardiac biomarker alterations. It is important to note that nearly half of MIs are not preceded by a previous angina symptom, and up to 1/3 present with STEMI as the first symptomatic manifestation of coronary disease. MI can occur in various regions of the heart wall and may be described as anterior, inferior, posterior, lateral, subendocardial, and transmural, depending on its location and extent of tissue damage from infarction. 12-lead EKG helps localize the affected area through identification of changes in ST segments and T waves. In STEMI, and characteristic Q wave often develop on EKG some hours later. Cardiac troponin I, or CTNI, is the most specific indicator of MI and should be obtained on admission to the emergency department. Cardiac troponin I elevation is detectable 2 to 4 hours after onset of symptoms. Additional measurements within 6 to 9 hours and again at 12 to 24 hours are recommended if clinical suspicion is high and previous samples were negative. Troponin levels also can be used to estimate infarct size and therefore the likelihood of complications. Other biomarkers released by myocardial cells include CPK, MB, and LDH. Additional lab data may reveal leukocytosis and elevated CRP, both of which indicate inflammation. The individual's blood glucose level is usually elevated and the glucose tolerance level may remain abnormal for several weeks. Individuals with acute coronary syndrome require admission to the hospital. The individual should be placed on supplemental oxygen and given an aspirin immediately. Plavix or Presergal if intolerant to aspirin. Pain is treated with morphine sulfate, which also has vasodilatory effects on the coronaries. Continuous monitoring of cardiac rhythm and biomarker changes is essential because the first 24 hours after onset of symptoms is the time of highest risk for sudden death. Non-STEMI is treated in the same way as unstable angina, including antithrombotics, anticoagulation, or PCI, or both. STEMI is best managed with emergent PCI and antithrombotics. Careful monitoring for dysrhythmias, heart failure, and shock is essential. Hyperglycemia is treated with insulin. Once the person is stabilized, further management includes ACE inhibitors, beta blockers, and statins. Bed rest, followed by gradual return to activities of daily living, reduces the myocardial oxygen demands of the compromised heart. Individuals not receiving thrombolytic or heparin infusion must receive deep vein thrombosis prophylaxis as long as their activity is significantly limited. Stool softeners are given to eliminate the need for straining. Education on diet, caffeine, smoking cessation, exercise, and other aspects of risk factors reduction is crucial for secondary prevention of recurrent myocardial ischemia. Approximately 1 to 2 of people initially diagnosed with STEMI do not have myocardial infarction, but rather have a stress-induced syndrome known as the broken heart syndrome or Takotsubo cardiomyopathy. These individuals present with the acute onset of chest pain, ST elevation, and elevated troponins after emotional stress, but generally do not have coronary artery disease and must be managed differently. So what complications may we face? The number and severity of post-infarction complications depend on the location and extent of necrosis, the individual's physiologic condition before the infarction, and the availability of swift therapeutic intervention. Dysrhythmias or arrhythmias, which are disturbances of cardiac rhythm, are the most common complication of acute MI. Dysrhythmias can be caused by ischemia, hypoxia, autonomic nervous system imbalances, lactic acidosis, electrolyte abnormalities, alterations of impulse conduction pathways, or conduction defects, jerk toxicity, or hemodynamic abnormalities. Dysrhythmias may originate from the atria, ventricles, nodal regions, or conduction tissues. The seriousness of dysrhythmias depend on the hemodynamic consequences. Prophylactic use of antiarrhythmics, such as lidocaine and amiodarone, does not improve mortality. However, individuals at high risk should be considered for implantable cardioverter defibrillators, or ICDs. Acute MI is accompanied by functional impairment of the myocardium. Many infarctions result in some degree of heart failure, which is characterized by pulmonary congestion, reduced myocardial contractility, and abnormal heart wall motion. Anterior infarction is associated with more severe left heart failure than is inferior infarction. If cardiac output is insufficient to maintain normal arterial pressure and to perfuse the kidneys and other organs adequately, cardiogenic shock develops. Inflammation of the pericardium, or pericarditis, is a common complication of acute MI. Pericardial friction rub often are noted 2 to 3 days after MI and are associated with anterior chest pain that worsens with respiratory effort. Specific treatment is not required. However, corticosteroids dramatically relieve symptoms. Cardiac complications of MI can include rupture of heart structures and aneurysm formation. Tissue necrosis in or around the papillary muscle can cause ruptures of these muscles or of the chordae tendineae. Weakening of the wall of the infarcted ventricle can cause ventricular aneurysm formation. Left ventricular aneurysm is a late complication of MI, occurring months or years after the acute event. The ventricle wall bulges with systole, resulting in impaired pump function and a significant risk for dysrhythmias. Although rare, ruptures may occur when the tension becomes too great. Thromboembolism is found during postmortem examination of many individuals who have died of MI. Thromboemboli may disseminate from debris and clots that collect inside dilated aneurysmal sacs or from the infarcted endocardium and travel to the pulmonary or systemic vascular systems. Pulmonary emboli also may result from the breaking loose of deep vein thrombi of the legs in the individuals who are confined to bed. Early mobilization and prophylactic anticoagulation therapy are essential to reduce the incidence of this complication. Several factors contribute to the risk of death during acute infarction or reduce the chances of long-term survival despite the best possible treatment. They are 1. The degree of the left ventricular dysfunction, 2. The degree of the left ventricular ischemia, 3. The potential for ventricular dysrhythmias, and 4. The individual's age. Disorders of the heart wall, disorders of the pericardium. Pericardial disease is often a manifestation of another disorder, such as infection, whether bacterial, viral, fungal, rickettsial, or parasitic, trauma or surgery, neoplasm or a metabolic, immunologic, or vascular disorder, such as uremia, rheumatoid arthritis, systemic lupus, erythematosus, periarteritis nodosa. The pericardial response to injury from these diverse causes may consist of acute pericarditis, pericardial effusion, or constrictive pericarditis. So what is acute pericarditis? Acute pericarditis is an acute inflammation of the pericardium. The etiology of acute pericarditis is most often idiopathic or autoimmune, or caused by a viral infection. Other causes include MI, trauma, neoplasm, surgery, uremia, bacterial infection, especially tuberculosis, or a conductive tissue disease, such as systemic lupus or rheumatoid arthritis. Can also be induced by radiation therapy. The pericardial membrane becomes inflamed and roughened, and the pericardial effusion may develop that can cause serious, purulent, or fibrinous. Possible sequelae of pericarditis include recurrent pericarditis, pericardial constriction, and cardiac tamponade. So here we're looking at a heart that has acute pericarditis, where you can see that the heart is not nice and pink, but rather light pink and inflamed. Symptoms may follow several days of fever and usually begin with sudden onset of severe retrosternal chest pain that worsens with respiratory movement and when assuming a recumbent position. The pain may radiate to the back as a result of irritation of the phrenic nerve, innervates the trapezius muscles. As it traverses the pericardium, individuals with acute pericarditis also report dysphagia, restlessness, irritability, anxiety, weakness, and malaise. Physical examination often discloses a low-grade fever and sinus tachycardia. A friction rub, a scratchy grating sound, may be heard at the cardiac apex and left sternal border, and is caused by the roughened pericardial membranes rubbing against each other. Friction rubs are not always present and may be intermittently heard and transient. Serum measures of inflammation such as a hsCRP are elevated. Electrocardiographic changes may reflect inflammatory processes through PR segment depression and diffuse ST segment elevation without Q waves. They may remain abnormal for days or even weeks. Ultrasound, CT scanning, and MRI may be used as diagnostic modalities. Acute pericarditis requires at least two of the following four criteria to be diagnosed positively. Chest pain characteristic of pericarditis, a pericardial rub, characteristic of electrocardiographic changes in our EKG, and new or worsening pericardial effusions. Treatment for uncomplicated acute pericarditis relies on the use of anti-inflammatory medications, combined non-steroidal anti-inflammatory medications, and colchicine, which prevents the fibrosis, is a highly effective regimen. The level of hsCRP in the blood should be followed to determine resolution before discontinuation of treatment. Additional analgesics may be given to relieve pain. Exploring the underlying cause is important. If pericardial effusion develops, aspirating the excessive fluid may be necessary. Which leads us to pericardial effusion. Pericardial effusion is the accumulation of fluid in the pericardial cavity. It can occur in all forms of pericarditis. Most are idiopathic, about 20%, but other causes such as a neoplasm and infection must be considered. The fluid may be transitate, such as the serous effusion that develops with left heart failure, overhydration, and hypoproteinemia. More often, however, the fluid isn't exudate, which indicates pericardial inflammation, like that seen with acute pericarditis. Heart surgery, chemotherapy agents, infection, and autoimmune disorders, such as systemic lupus. If the fluid is serosanguinous, the underlying cause is likely to be tuberculosis, neoplasm, uremia, or radiation. Effusions of frank blood are generally related to aneurysms, trauma, or coagulation defects. If Schilly leaks from the thoracic duct, it may be a pericardium and lead to cholesterol pericarditis. Pericardial effusion may create sufficient pressure to cause cardiac compression, which is a serious condition known as tamponade. If an effusion develops gradually, the pericardium can stretch to accommodate large quantities of fluid without compressing the heart. If the fluid accumulates rapidly, however, even a small amount, 50 to 100 ml, may cause serious tamponade. The danger is that pressure exerted by the pericardial fluid will eventually equal diastolic pressure within the heart chambers, which will interfere with right atrial filling during diastole. This causes increased venous pressure, systemic venous congestion, and signs and symptoms of right heart failure, distension of the jugular veins, edema, and hepatomegaly. Decreased atrial filling leads to decreased ventricular filling, decreased stroke volume, and a reduced cardiac output. Individuals with cardiac tamponade most often present with dyspnea, tachycardia, jugular venous distension, cardiomegaly, and pulsus paradoxus. Pulsus paradoxus means that the arterial blood pressure during expiration exceeds the arterial pressure during inspiration by more than 10 milligrams of mercury. This clinical finding reflects impairment of diastolic filling of the left ventricle, plus reduction of the blood volume within all four cardiac chambers. Other clinical manifestations of pericardial effusion are distant or muffled hurt heart sounds, poorly palpable apical pulses, dyspnea on exertion, and dull chest pain. A chest X-ray may disclose a water bottle configuration of the cardiac silhouette. An echocardiogram can detect an effusion as small as 20 ml and is considered the most accurate and reliable method of diagnosis, although CAT scan and MRI also are used. Treatment of pericardial effusion or tamponade generally consists of pericardiocentesis, or aspiration of excessive pericardial fluid. Pericardial centesis is diagnostic and therapeutic. The fluid is analyzed to identify the cause of the effusion, and its removal alone may bring dramatic relief from symptoms. Removal of large amounts of fluid may be associated with pericardial decompression syndrome, a potentially fatal condition complicated by pulmonary edema and cardiovascular shock. Persistent pain may be treated with analgesics, anti-inflammatory medications, or steroids. Surgery may be required if the underlying cause of tamponade is trauma or aneurysm. If an effusion or neoplasm-induced sclerosing agent may be injected into the pericardial space. Recurrent pericardial effusions may require surgical creation of a pericardial window that allows for continual drainage and prevent tamponade. Constrictive pericarditis. Constrictive pericarditis or restrictive pericarditis, or known as chronic pericarditis, was once synonymous with tuberculosis in the US. This form of pericardial disease is more often idiopathic or associated with radiation exposure, heart surgery, including transplantation, acute pericarditis, rheumatologic disease, trauma, or malignancy. In constrictive pericarditis, fibrous scarring with occasional calcification of the pericardium causes the visceral and parietal pericardial layer to adhere, obliterating the pericardial cavity. The fibrotic lesions encase the heart in a rigid shell. Like tamponade, constrictive pericarditis compresses the heart, which impairs ventricular relaxation during diastole, reduces ventricular filling, and eventually reduces cardiac output. Because the onset of constrictive pericarditis is gradual, clinical manifestations develop slowly. Symptoms include exercise intolerance, dyspnea on exertion, fatigue, and anorexia. Approximately 2/3 of individuals present with heart failure. Clinical assessments show edema, jugular vein distension, and hepatic congestion. Restricted ventricular filling may cause a pericardial knock, early diastolic sound. EKG findings include T-wave inversions and atrial fibrillation. Chest X-ray often discloses prominent pulmonary vessels and a calcification of the pericardium. CT, MRI, and transesophageal echocardiograph, or TEE, are used to detect pericardial thickening and constriction. Pericardial biopsy may be needed to determine the etiology. Initial treatment for chronic constrictive pericarditis consists of dietary sodium restriction and diuretics. Management also may include use of anti-inflammatory drugs and treatment of any underlying disorder. If these modalities are not successful, surgical excision of the restrictive pericardium, a pericardiectomy, is indicated. Disorders of the myocardium, the cardiomyopathies. The cardiomyopathies are a diverse group of diseases that affect the myocardium. Most are the result of remodeling caused by the effect of a neurohumoral response to ischemic heart disease or hypertension on the heart muscle. Cardiomyopathies also can be secondary to inherited disorders, infectious diseases, exposure to toxins, systemic connective tissue disease, infiltrative or proliferative disorders, or nutritional deficiencies. Many cases of cardiomyopathy are idiopathic. The cardiomyopathy are categorized as dilated, hypertrophic, or restrictive, depending on their tissue characteristics, genomics, and hemodynamic effect. An individual may display characteristics of more than one type. So here we're taking a look at the different types of cardiomyopathies. We have a normal heart, and we're looking specifically here at the left atrium, the left ventricle, and the aorta. In a dilated cardiomyopathy, you can see that the left ventricle is much larger. In a hypertrophic cardiomyopathy, you can see that the muscle wall of the left ventricle has kind of decreased the potential volume that blood can flow into. And then you have a restrictive, where again, it is a very small, like it's a much smaller ability. Let me rephrase that. In picture D, even though the volume is the same in the sense that your left ventricle still has the same filling action, the muscle wall is thickened, and therefore it doesn't have the same space it does to beat. So now it's bouncing up against, other cavities within the body. So it can't open and close as well as it would like. It has the option to, however, because of the physical nature of how much cardiac muscle there is around that ventricle, it makes it much more difficult. So a dilated cardiomyopathy. Dilated cardiomyopathy is usually the result of ischemic heart disease, valvular disease, diabetes, renal failure, alcohol or drug toxicity, hyperthyroidism, nutritional deficiencies such as niacin, vitamin D, and selenium, or infection. Peripartum cardiomyopathy occurs in previously healthy women in the final month of pregnancy and up to 5 months after delivery and can lead to shock. Dilated cardiomyopathy also can be associated with inherited disorders. This form of cardiomyopathy is characterized by impaired systolic function, leading to an increase in intracardiac volume, ventricular dilation, and heart failure with reduced ejection fraction. Arrhythmias are common due to the pathophysiologic effect of the cardiomyopathy. Individuals complain of dyspnea, fatigue, and pedal edema. Findings on examination include a displaced apical pulse. There is an S3 gallop, peripheral edema, jugular venous distension, and pulmonary congestion. Diagnosis is confirmed via a chest X-ray and echocardiogram, and management is focused on reducing blood volume, increasing contractility, and reversing the underlying disorder if possible. Heart transplantation is required in severe cases. So here's our dilated heart. Then looking at the hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy refers to two major categories of thickening in the myocardium. The hypertrophic obstructive cardiomyopathy, an asymmetrical septal hypertrophic cardiomyopathy, or the idiopathic hypertrophy, a subaortic stenosis, and 2. A hypertensive or valvular hypertrophic cardiomyopathy. Two categories are very different in their etiology. the pathophysiology, and clinical presentation. So there's two types. Type 1, the hypertrophic obstructive cardiomyopathy is the most common. It's inherited heart defect associated with left ventricular hypertrophy, occurring in 1 out of 500 individuals through autosomal dominant inheritance. It's characterized by a thickening of the septal wall, which may cause outflow obstruction to the left ventricle outflow tract. Additional changes include abnormalities of collagen deposition and altered contractile proteins in the myocytes. The thickening of the septum results in the hyperdynamic state, especially with exercise. Obstruction of the left ventricular outflow can occur when the heart rate is increased and the intravascular volume is decreased. Individuals complain of angina, syncope, palpitation, and symptoms of an MI and left heart failure. Sudden death may occur. Examination may reveal extra heart sounds and murmurs. An echocardiogram and MRI are used to confirm the diagnosis and determine the best therapeutic approach. Management includes beta blockers to slow the heart rate, ACE inhibitors to reverse hypertrophic changes, and surgical resection or ablation of the hypertrophied myocardium. Placement of an implantable cardioverter or defibrillator significantly decreased the risk of an arrhythmia-related sudden death. So here we're looking at the hypertrophy portion of cardiomyopathy. There is a marked left ventricular hypertrophy. This often affects the septum, the S. So you can see there's not that opening that we normally like in the heart so that blood can flow. Hypertensive or valvular hypertrophic cardiomyopathies occur because of an increased resistance to ventricular ejection. It is commonly seen in hypertension or in valvular stenosis, usually aortic. In this case, hypertrophy of the myocyte is an attempt to compensate for the increased myocardial workload. Long-term dysfunction of the myocytes develop over time, with first diastolic dysfunction leading eventually to systolic dysfunction of the ventricle. Individuals with hypertrophic cardiomyopathy may be asymptomatic or may complain of angina, syncope, dyspnea on exertion, and palpitations. Examination may reveal extra heart sounds and murmurs. Echocardiography and cardiac catheterization can confirm this diagnosis. This leads us to restrictive cardiomyopathies. Restrictive cardiomyopathies is characterized by the restrictive filling and reduced diastolic volume of either or both ventricles, with normal or near normal systolic function and wall thickness. It may occur idiopathically or as a cardiac manifestation of systemic disease, such as scleroderma, amyloidosis, sarcoidosis, lymphedema, and hemochromatosis, or a number of inherited storage diseases. The myocardium becomes rigid and non-compliant, impeding ventricular filling and raising filling pressures during diastole. The overall clinical and hemodynamic picture mimics and may be confusing with that of constrictive pericarditis. The most common clinical manifestation of restrictive cardiomyopathy is right heart failure with systemic venous congestion. Cardiomegaly and dysrhythmias are common. A thorough evaluation for the underlying cause should be initiated and may include myocardial biopsy. Treatment is aimed at the underlying cause. However, many individuals require placement of a left ventricular assistive device, or an LVAD, followed by heart transplantation. This leads us to disorders of the endocardium. Valvular dysfunction. That's been mentioned several times now. So, valvular dysfunction is disorders of the endocardium, the innermost lining of the heart wall. Damage the heart valves, which are made up of endocardial tissue. Endocardial damage can be either congenital or acquired. Congenital valvular diseases are discussed in Chapter 4, and it should already be linked into the chapters that have been read. The acquired forms results from inflammatory, ischemic, traumatic, degenerative, or infectious alterations of valvular structure and function. Structural alterations of the heart valves result from remodeling changes in the valvular extracellular matrix and lead to stenosis, regurgitation, or both. Although all four heart valves may be affected, those of the left heart, your mitral and aortic valves, are more commonly affected than those of the right heart, your tricuspid and pulmonic valve. In valvular stenosis, the valve orifice is constricted and narrowed, impeding the forward flow of blood and increasing the workload of the cardiac chamber proximal to the diseased valve. Intraventricular or atrial pressure increases in the chamber to overcome resistance to flow through the valve. Increased pressure causes myocardium to work harder, causing a myocardial hypertrophy. In valvular regurgitation, also called insufficiency or incompetence, the valve leaflets or cusps fail to shut completely, permitting blood flow to continue even when the valve is supposed to be closed. During systole or diastole, some blood leaks back into the chamber proximal to the incompetent valve, producing a murmur on auscultation. Valvular regurgitation increases the volume of blood the heart must pump and increase the workload of the affected heart chamber. Increased volume leads to chamber dilation, and increased workload leads to hypertrophy. So if we have here a normal heart valve, and it's open, and then it closes. However, during stenosis, if it's open, it's not fully closed, and during regurgitation, there's again, that cusp doesn't fully close. So there's that leakage. So either the leakage comes when it's trying to fill, and then the heart doesn't have to squeeze proper, or when it's trying to squeeze out, it's squeezing back up, or not squeezing all the way through. So valvular dysfunction stimulates chamber dilation and or myocardial hypertrophy, both of which are compensatory mechanisms intended to increase the pumping capability of the heart. Eventually, myocardial contractility is diminished, the ejection fraction is reduced, diastolic pressure increases, and the affected heart chamber fails from overload. Depending on the severity of the valvular dysfunction and the capacity of the heart to compensate, valvular alterations cause a range of symptoms and some degree of incapacitation. In general, valvular disease is diagnosed by transthoracic echocardiography, or TTE, which can be used to assess the severity of valvular obstruction or regurgitation before the onset of symptoms. A CAT scan or MRI may also be indicated in certain settings. Valvular lesions are staged using four general categories: the at risk, the progressive, that there is asymptomatic severe, or the symptomatic severe, which determine the, appropriate management style. Management almost always includes a careful medical management, valvular repair, or valve replacement, before long-term anticoagulation therapy and prophylaxis for endocarditis is needed. The purpose of valvular intervention is to improve symptoms and prolong survival, as well as to minimize complications such as asymptomatic irreversible ventricular dysfunction, coronary hypertension, stroke, or atrial fibrillation. So that leads us to aortic stenosis. Aortic stenosis is the most common valvular abnormality, affecting approximately 5% of adults older than 75. And the most common causes are the calcified degeneration related to aging, so your aortic sclerosis. There is a congenital bicuspid valve or an inflammatory damage caused by rheumatic heart disease. Aortic sclerosis affects up to 40% of those older than the age of 75 and about 2% per year, progressing to hemodynamically significant aortic stenosis, whereas congenital bicuspid aortic valve occurs only at 0.5 to 0.8% of the population. Your rheumatic heart disease is a less frequent case of aortic stenosis. The pathophysiology of aortic stenosis is complex, and numerous gene abnormalities have been implicated, including polymorphism of the genes that code for LDL. Aortic stenosis results from a lipoprotein deposition in the valve tissue with chronic inflammation and leaflet calcification. Autoimmunity disorders and calcium transport apoptosis of the endocardial cells, and decreased nitric oxide synthesis have been implicated. In aortic stenosis from any cause, the orifice of the aortic semilunar valve narrows, causing diminished blood flow from the left ventricle into the aorta. Outflow obstruction increases pressure within the left ventricle as it tries to eject blood through the narrowed opening. Left ventricular hypertrophy develops to compensate for the increased workload. Eventually, hypertrophy increases myocardial oxygen demand that the coronary arteries may not be able to supply. If this occurs, ischemia may cause attacks of angina. Untreated aortic stenosis can lead to dysrhythmias, myocardial infarcts, and overall heart failure. The good thing is, aortic stenosis tends to develop gradually. The classic manifestations of aortic stenosis are angina, syncope, and heart failure. Clinical manifestations include a decreased stroke volume, reduced systolic blood pressure, and a narrowed pulse pressure, the difference between systolic and diastolic pressure. The heart rate is often slow and pulses are faint. Resistance to flow through the stenotic valve gives rise to the crescendo-decrescendo systolic heart murmur, heard best at the second intercostal space, and may radiate to the neck. An echocardiogram is used to follow valve orifice and cardiac functioning. Medical management with careful monitoring for complications such as heart failure and myocardial ischemia may be indicated for selected individuals. Surgical valve replacement with either a mechanical or a bioprosthetic valve is indicated for both symptomatic and asymptomatic individuals with severe stenosis. A transcatheter aortic valve replacement, or TAVR, is used increasingly to avoid major heart surgery in selected individuals. The prognosis is poor once an individual becomes symptomatic from aortic stenosis. Your mitral stenosis. Mitral stenosis impairs the flow of blood from the left atrium to the left ventricle. Mitral stenosis is the most common form of rheumatic heart disease. Autoimmune activation of lymphocytes and macrophages leads to the inflammatory damage and subsequent scarring of the valve leaflets. Scarring causes the leaflets to become fibrous and fused, and the chordae tendineae cordis becomes shortened. Impedance to the blood flow results in incomplete emptying of the left atrium and elevated atrial pressure as the chamber tries to force blood through the stenotic valve. Continued increase in that left atrial volume and pressure cause chamber dilation and hypertrophy, and eventually result in a pulmonary hypertension. The outcome of untreated chronic mitral stenosis are pulmonary hypertension and a right ventricular failure. The risk of developing atrial dysrhythmias, especially fibrillation, and a dysrhythmia-induced thrombi is high. So here you're taking a look at the mitral stenosis, which has a classic fish mouth. The clinical manifestations depend on the size and the valvular orifice. As mitral stenosis progresses, symptoms of decreased cardiac output occur, especially during exertion. Blood flow through the stenotic valve gives rise to the rumbling crescendo diastolic murmur, heard best over the cardiac apex, and radiating to the left axilla. If the mitral valve is forced open during diastole, it may make a sharp noise called an opening snap. The first heart sound, your S1, is often accentuated and somewhat delayed because of an increased left atrial pressure. Other signs and symptoms, such as jugular venous distension and peripheral edema, result from pulmonary congestion and right heart failure. Atrial enlargement is demonstrated by a chest X-ray and electrocardiography. Mitral stenosis can often be repaired with a percutaneous balloon commissurotomy, but valve replacement may be required in advanced cases. New, minimally invasive procedures for mitral valve replacement are being explored, including a percutaneous transcatheter technique. That leads us to aortic regurgitation, which is a result from an inability of the aortic valve leaflets to close properly during a ventricular diastole, resulting from abnormalities of the leaflets or the aortic root, or both. It can be primary, caused by the congenital bicuspid valve disease or degeneration, or secondary, caused by chronic hypertension, rheumatic heart disease, bacterial endocarditis, syphilis, connective tissue disorder, Marfan syndrome, and ankylosing spondylitis, appetite-suppressing medications, trauma, and atherosclerosis. More than one-third of cases of aortic regurgitation are idiopathic. The hemodynamic repercussions depend on the size of the leak. During systole, blood is ejected from the left ventricle and into the aorta. During diastole, some of the ejected blood flows back into the left ventricle through the leaking valve. Volume overload occurs in the ventricle because it receives blood from the left atrium and the aorta during diastole. As the end diastolic volume of the left ventricle increases, myocardial fibers stretch to accommodate the extra fluid. Compensatory dilation permits the left ventricle to increase its stroke volume and maintain cardiac output. Ventricular hypertrophy also occurs as an adaptation to the increased volume and increased afterload created by the high stroke volume and resultant systolic hypertension. Ventricular dilation and hypertrophy eventually cease to compensate for aortic incompetence, and heart failure develops. Clinical manifestations include a widened pulse pressure, resulting from increased stroke volume and diastolic backflow. Turbulence across the aortic valve produces a diastolic decrescendo murmur, heard best in the second, third, or fourth intercostal space, peristernally, and may radiate to the neck. Large stroke volume and rapid runoff of blood from the aorta cause prominent carotid pulsation and bounding peripheral pulses, also known as Corrigan pulse. Other symptoms are usually associated with heart failure that occur when the ventricle can no longer pump adequately. Dysrhythmias and endocarditis are common complications of aortic regurgitation. The severity of regurgitation can be estimated by an echocardiography, and surgical and transcatheter valve replacement may be delayed for many years through careful use of vasodilators and inotropic agents. This leads us to mitral regurgitation. Mitral regurgitation occurs in approximately 1.7% of the US population. It can be primary, because of mitral valve prolapse, rheumatic heart disease, infective endocarditis, myocardial infarct, connective tissue disease such as Marfan syndrome, and dilated cardiomyopathies. It can also be secondary because of the ischemic or non-ischemic myocardial disease that damages the chordae tendineae or the mitral annulus. Mitral regurgitation permits backflow of blood from the left ventricle into the left atrium during ventricular systole, giving a rise to the loud pansystolic or throughout systole murmur, heard best at the apex that radiates into the back and axilla. The volume of backflow re-enters the left atrium, gradually increasing, causing atrial dilation and associated atrial fibrillation. As the left atrium enlarges, the valve structures stretch and become deformed, leading to further backflow. The increased volume in the left atrium increases the volume that enters the left I just lost my spot. The increased volume in the left atrium increases the volume that enters the ventricle. The left ventricle becomes dilated and hypertrophied to maintain adequate cardiac output. As mitral valve regurgitation progresses, left ventricular function may become impaired to the point of failure. Eventually, increased atrial pressure also causes pulmonary hypertension and failure of the right ventricle. Mitral incompetence is usually well tolerated, often for years, until ventricular failure occurs. Most clinical manifestations are caused by heart failure. The severity of regurgitation can be estimated via an echo, and surgical repair or valve replacement may become necessary. In acute mitral regurgitation caused by an MI, surgical repair or replacement must be done emergently. Our tricuspid regurgitation. Tricuspid regurgitation is more common than tricuspid stenosis and usually is associated with dilation and failure of the right ventricle, secondary to pulmonary hypertension. Rheumatic heart disease and infective endocarditis are less common causes. The tricuspid valve has the incompetence that leads to volume overload in the right atrium and ventricle, increased systemic venous blood pressure, and right heart failure. Pulmonic valve dysfunction can have the same consequences as tricuspid valve dysfunction, which leads us to the mitral valve prolapse syndrome. The mitral valve prolapse syndrome is a condition in which the anterior and posterior cusps of the mitral valve billow upward and they prolapse into the atrium during systole. To maintain competency, the mitral valve must be supported by what is called the mitral valve complex, which includes the annulus, leaflets, chordae tendineae, papillary muscles, and the left ventricular wall. Dysfunction of any of these elements can lead to a prolapse of the valve. The most common cause of mitral valve prolapse is myxomatous degeneration of the leaflets, in which the cusps are redundant, thickened, and scalloped because of the changes in tissue, proteoglycans, increased proteinases, and infiltration by myofibroblasts. The chordae tendineae may be elongated, permitting the valve cusps to stretch upward. Mitral regurgitation occurs if the ballooning valve permits blood to leak into the atrium. Mitral valve prolapse is the most common valve disorder in the United States, with a prevalence estimated around 3%. Mitral valve prolapse tends to be the most prevalent in young women. Genetic studies suggest several candidate genes that influence cardiac fibroblast and endothelial cell function. Because the mitral valve prolapse often is associated with other inherited connective tissue disorders, your Marfan syndrome, your Ehlers-Danlos syndrome, and osteogenesis imperfecta, it is thought to result from a genetic or environmental disruption of valvular development during the 5th or 6th week of gestation. There may also be a relationship between the symptomatic mitral valve prolapse and hyperparathyroidism or hyperthyroidism. Many cases of mitral valve prolapse are completely asymptomatic. Cardiac auscultation on routine physical exam may disclose a regurgitant murmur or a mid-systolic click in an otherwise healthy individual. Echocardiograms may demonstrate the condition in the absence of oscillatory findings. Symptomatic mitral valve prolapse can cause palpitations related to dysrhythmias, tachycardia, lightheadedness, syncope, fatigue, especially in the morning, lethargy, weakness, dyspnea, chest tightness, hyperventilation, anxiety, depression, panic attacks, and atypical chest pain. Many symptoms are vague and puzzling and are unrelated to the degree of prolapse. Most individuals with mitral valve prolapse have an excellent prognosis, do not develop symptoms, and do not require any restriction in activity or medical management. Occasionally, beta blockers are needed to alleviate syncope, severe chest pain, or palpitations. Surgical repair is only necessary if significant mitral regurgitation develops. Acute rheumatic fever and rheumatic heart disease. Rheumatic fever is a systemic inflammatory disease caused by an immune and inflammatory response to infection by group A beta hemolytic streptococci in genetically predisposed individuals. In its acute form, rheumatic fever is a febrile illness that occurs approximately 2 to 3 weeks after infection and is characterized by inflammation of the joints, skin, nervous system, and heart. If left untreated, rheumatic fever can cause scarring and deformity of cardiac structures, resulting in rheumatic heart disease. The incidence of acute rheumatic fever declined in the US during the 1960s, 70s, and 80s because of medical and socioeconomic improvements, as well as changes in the virulence of the group A streptococci. It occurs most often in children between 5 and 15. Appropriate antibiotic therapy given within the first 9 days of infection usually prevents rheumatic fever. Individuals who have experienced one attack of acute rheumatic fever are more susceptible to recurrent attacks. So how does it work? Acute rheumatic fever can develop only as a sequela to pharyngeal infection by group A beta hemolytic streptococci. Streptococcal skin infection do not progress to acute rheumatic fever because the strains of the microorganism that infect the skin do not have the same antigenic molecule in their cell membrane as do those that cause pharyngitis and therefore do not elicit the same kind of immune response. Acute rheumatic fever is the result of an abnormal humoral and cell-mediated immune response to the M proteins on the microorganism that cross-react with normal tissue. Antibodies against streptococci bacterial antigens display cross-reactivity against laminin, a protein present in extracellular tissue around heart cells and in the valves. Cardiac myosin and vimentin are other target antigens. Autoimmunity and associated intense inflammation result in diffuse proliferative and executive lesions in the connective tissues, especially in the heart, joints, and skin. Repeated attacks of acute rheumatic fever cause chronic proliferative changes, with resultant scarring, granulomas, and thrombosis. Approximately 10% of cases of rheumatic fever develop RHD, or rheumatic heart disease. It begins as carditis or inflammation of the heart. Although rheumatic fever can cause carditis in all 3 layers of the heart wall, your endocardium, myocardium, and pericardium, the primary lesion usually involves the endocardium, which includes the heart valves. Endocardial inflammation causes swelling of the valve leaflets with secondary erosion along the lines of leaflet contact. Small bead-like clumps of vegetation containing platelets and fibrin are deposited or eroded valvular tissue and on the chordae tendineae. The valves lose their elasticity, and the leaflets may adhere to each other. Scarring and shortening of the involved structure occur over time. If inflammation penetrates the myocardium, localized fibrin deposits develop that are surrounded by areas of necrosis. These fibrinoid necrotic deposits are called Aschoff bodies. Pericardial inflammation is usually characterized by serofibrinous effusion within the pericardial cavity. Cardiomegaly and left heart failure may occur during episodes of untreated acute or recurrent rheumatic fever. Conduction defects and atrial fibrillation often are associated with rheumatic heart disease. Common symptoms of acute rheumatic fever are fevers, lymphadenopathy, arthralgia, nausea, vomiting, epistaxis or nosebleeds, abdominal pain, and tachycardia. The major clinical manifestation of acute rheumatic fever: carditis, acute migratory polyarthritis, subcutaneous nodules, chorea, and erythema marginatum. Usually occurs singly or in a combination of 1 to 5 weeks after streptococcal infection of the pharynx. Carditis. Carditis occurs a few weeks after the initial infection in about 50% of patients with acute rheumatic fever, with the mitral valve being the most affected structure. Cardiac manifestations of acute rheumatic fever may be a previously undetected murmur caused by mitral or aortic valve dysfunction, chest pain, and pericardial rub caused by pericardial inflammation or unexplained cardiomegaly with heart failure. Polyarthritis is an acute migratory asymmetrical polyarthritis, the inflammation of more than one joint, poly, occurs in the majority of individuals with rheumatic fever, although a severe monoarthritis also is a presenting feature in a high-risk population. Although all of the synovial joints may be involved, the large joints of the extremities are most often affected. 2 or more joints are usually involved, simultaneously or in succession, with each joint being symptomatic for approximately 2 to 3 days, while the overall polyarthritis continues for up to 3 weeks. Exudative synovitis causes heat, redness, swelling, severe pain, and tenderness, but no permanent disability. Subcutaneous nodules. Palpable subcutaneous nodules occur in less than 5% of cases of acute rheumatic fever. They develop over bony prominences and along extensor tendons of elbows, wrists, knees, and ankles. They do not interfere with joint function and often go unnoticed. Chorea. The Sydenham chorea, or St. Vitus dance, is a disorder in the CNS characterized by sudden, aimless, irregular, involuntary movements. It can affect up to 15% of the people with rheumatic fever and is the most common acquired chorea in children. The chorea is self-limiting, although severe cases may require the use of dopamine receptor blockers and anti-epileptic medications. It resolves within 1 to 3 months and has no permanent neural sequelae. The erythema marginatum is a common manifestation and presents as a distinctive truncal rash that often accompanies acute rheumatic fever. It consists of an annular erythema with the appearance of non-pruritic pink erythematous macules that spread outward. The rash is transitory and may change in appearance within minutes or hours. The evaluation and treatment. The original Jones criteria for the diagnosis of rheumatic fever have been updated by the American Heart Association. Supportive evidence for Group A beta hemolytic streptococci includes positive throat cultures and measurement of serum antibodies against the hemolytic factor streptolysin O. Cultures may be negative, when the rheumatic attack begins. However, several other antibody tests are sensitive prognosticators of streptococcal infection, including the anti-deoxyribonuclease B, or anti-DNase B, an anti-hyaluronidase, and an anti-streptozyme, or ASTZ. Elevated measurements of white blood cell count, erythrocyte sedimentation rate, and C-reactive protein indicate inflammation. All three are usually increased at the time of cardiac or joint symptoms begin to appear. Therapy for acute rheumatic fever is aimed at eradicating the streptococcal infection using a 10-day regimen of antibiotics. NSAIDs are used as anti-inflammatory agents for rheumatic carditis and arthritis and help relieve symptoms, but they do not prevent complications. Serious carditis may require diuretics and vasodilators, and recovery can take up to 12 months. Surgical repair of damaged valves may be necessary in cases of chronic recurrent rheumatic fever or carditis. Persistent chorea requires psychological support, protection against falls and injury, and treatment with anti-epileptic or neuroleptic medications. NSAIDs or paracetamol may provide symptom relief from arthralgias, because recurrent rheumatic fevers occur in more than half of the affected children. Continuous prophylactic antibiotic therapy may be necessary for as long as 5 years. This leads us to infective endocarditis. Infective endocarditis, or IE, is a general term used to describe infection and inflammation of the endocardium, especially the cardiac valves. The incidence of IE is increasing in the US, in large part because there is an increase in the implantation of prosthetic valves. Bacteria are the most common cause of infective endocarditis, with a Staphylococcus aureus, the most common causative agent worldwide. Other causes include streptococci, enterococci, viruses, fungi, rickettsia, and parasites. The pathogenesis of IE requires at least 3 critical elements. Not sure what this pathway shows. The pathogenesis of infective endocarditis. Okay. So it could be congenital heart disease, valvular heart disease, trauma could be a procedural trauma, or a prosthetic valve. Anyway, any of those could cause endocardial damage. That damage causes inflammation and a thrombus formation. Due to that thrombus formation, now we have a sterile thrombotic endocarditis. Now, these could also occur due to a dental, genitourinary, a GU, or cardiac procedure, a skin, wound, lung, or GU infection, long-term indwelling catheters, or indwelling catheters that probably replaced in a non-sterile field, and injection drug use, your IV drug abusers. Anything that can cause bacteremia. Once that sterile thrombotic endocarditis gets in contact with bacterial adherents, same as if you got bacteremia, you now have bacterial adherents. It triggers that fibrin and thrombus formation, and from that formation, it triggers vegetation. That vegetation then becomes embolized. You might get fevers, night sweats, malaise, and weight loss. You might start hearing those murmurs, that regurgitant valve, and heart failure. If it does embolize, you can have abscesses, petechiae, splinter hemorrhages, those Osler nodes or the Janeway lesions. So, your trauma, your congenital heart disease, valvular heart disease, and the presence of a prosthetic valves are the most common risk factors for that endocardial damage that leads to infective endocarditis. Turbulent blood caused by the abnormalities usually affects the atrial surface of atrioventricular valves or the ventricular surface of the semilunar valves. Endocardial damage exposes the endothelium basement membrane, which contains a type of collagen that attracts platelets and thereby stimulates a sterile thrombus formation on the membrane. This causes an inflammatory reaction, a non-bacterial thrombotic endocarditis. Blood-borne microorganisms adherence to the damaged endocardial surface. The bacteria may enter the bloodstream during injection, drug use, trauma, a dental procedure that involves manipulation of the gingiva, cardiac surgery, genitourinary procedures, and indwelling catheters in the presence of infection, or a gastrointestinal instrumentation. May spread from uncomplicated upper respiratory tract or skin infection. Bacteria adhere to the damaged endocardium using adhesins. And 3. Formation of infective endocardial vegetation. Bacteria infiltrate the sterile thrombi and accelerate fibrin formation by activating the clotting cascade. These vegetative lesions can form anywhere on the endocardium, but usually occur on heart valves and the surrounding structures. Although endocardial tissue is constantly bathed in antibody-containing blood and is surrounded by scavenging monocytes and polymorphonuclear leukocytes, bacterial colonies are inaccessible to host defenses because they are embedded in the protective fibrin clots. Embolization from the vegetation can lead to the abscesses and characteristic skin changes, such as petechiae, splinter hemorrhages, and those Janeway lesions we mentioned earlier. Those are non-painful hemorrhagic lesions on the palms and soles of feet. So what kind of clinical manifestations do you see with infective endocarditis? Well, that depends. Is it acute, subacute, or chronic? It causes varying degrees of valvular dysfunction and may be associated with manifestations involving several organ systems: your lungs, eyes, kidneys, bones, joints, your central nervous system. Signs and symptoms of IE are caused by infection and inflammation, systemic spread of microemboli, and the immune complex deposition. The classic findings are fever, new or changed cardiac murmurs, and petechial lesions on the skin, conjunctiva, and oral mucosa. The characteristic physical findings include Osler nodules, whether they're painful erythematous nodules on the pads of the fingers and toes, and Janeway lesions. Other manifestations include weight loss, back pain, night sweats, and heart failure. Your CNS, your splenic, renal, pulmonary, and peripheral arterial, coronary, and ocular emboli will lead to a wide variety of signs and symptoms. So how do we evaluate and treat it? Well, the two widely accepted Duke criteria for the diagnosis of IE include the two major criteria of positive blood cultures. It needs to be at least two positive cultures drawn 12 hours apart, and evidence for endocardial involvement. The echo findings of vegetation and valvular dysfunction or damage, plus minor criteria including a predisposing condition, fever, evidence of emboli, your Janeway lesions, and an immunologic phenomena, such as your Osler nodes. The diagnosis of IE must be made as soon as possible to initiate appropriate empirical antibiotic therapy and to identify patients at high risk for complications. Antimicrobial therapy should begin as soon as possible, and it is generally continued for several weeks. Surgical intervention to repair or replace the valve may be required, especially in individuals with heart failure, abscess, infection with highly resistant microorganisms, and large vegetations. Antibiotic prophylaxis to prevent IE is indicated for those with prosthetic valves, a history of IE, unrepaired cyanotic congenital heart disease, and heart transplant with valvular defect in the setting of gingival procedures or in the presence of a documented acute gastrointestinal or gastrourinary infection. That brings us to the manifestations of the heart disease. Heart failure. Heart failure is defined as a pathophysiologic condition in which the heart is unable to generate an adequate cardiac output, such that inadequate perfusion of tissues or increased diastolic filling pressure of the left ventricle or both occurs. Consequently, pulmonary capillary pressures are increased. It is estimated that 5.7 million Americans at the age of 20 or more have heart failure, and it causes 1 in 9 deaths in the United States. Heart failure is a pressing worldwide problem, with millions of people experiencing worsening heart failure. Ischemic heart disease and hypertension are the most important predisposing risk factors, with 75% of heart failure cases occurring in individuals with hypertension. Other risk factors include age, smoking, obesity, diabetes, renal disease, valvular heart disease, cardiomyopathies, myocarditis, congenital heart disease, and excessive alcohol use. Numerous genetic polymorphisms have been linked to an increased risk for heart failure, including genes for cardiomyopathies, sarcomere proteins, neurohumoral receptors. Most causes of heart failure result in dysfunction of the left ventricle, systolic and diastolic heart failure. The right ventricle also may be dysfunctional, especially in pulmonary disease, the right ventricular failure. Finally, some conditions cause inadequate perfusion despite normal or elevated cardiac output, your high output failure. A current area of investigation is mitochondrial dysfunction. Mitochondrial abnormalities include impaired mitochondrial electron transport chain activity, increased formation of reactive oxygen species, altered metabolic substrate use, abnormal mitochondrial dynamics, and altered ion hemostasis. Abnormal mitochondrial energy production is involved in many symptoms found in individuals with heart failure and include skeletal muscle dysfunction and renal pathologies. So, what are our types of heart failure? We have our left heart failure. Left heart failure, or congestive heart failure, is categorized as heart failure with reduced ejection fraction, or HFrEF, systolic heart failure, or heart failure with a preserved ejection fraction, or HFpEF, a diastolic heart failure. These two types of heart failure can occur together in one individual or singly. So let's first look at a heart failure with a reduced ejection fraction. Heart failure with a reduced ejection fraction is defined as an ejection fraction of less than 40% and an inability of the heart to generate an adequate cardiac output to perfuse vital tissues. Cardiac output depends on the heart rate and stroke volume. Stroke volume is influenced by three major factors: the contractility, preload, and afterload. Contractility is reduced by disease, that disrupts myocyte activity. Myocardial infarction is the most common cause of decreased contractility. Other causes include myocarditis and cardiomyopathies. These diseases contribute to inflammatory, immune, and neurohumoral changes. The activation of the sympathetic nervous system and the renin-angiotensin-aldosterone system that mediate a process called a ventricular remodeling. Ventricular remodeling results in the disruption of the normal myocardial extracellular structure, with resultant dilation of the myocardium, and causes progressive myocyte contractile dysfunction over time. When contractility is decreased, stroke volume falls, and left ventricular and diastolic volume increases. This causes the dilation of the heart and the increase in preload. Preload, or left ventricular and diastolic volume, increases with decreased contractility or when there is an excess of plasma volume, your intravenous fluid administration, renal failure, or mitral valvular disease. This increase in preload can actually improve cardiac output up to a certain point, but as preload continues to rise, it causes a stretching of the myocardium that eventually leads to dysfunction of the sarcomere and decrease in contractility. This relationship is described by the Frank-Starling law of the heart. Increased afterload is most commonly a result of increased peripheral vascular resistance, such as seen with hypertension. Although much less common, it also can be the result of aortic valvular disease. With increased peripheral vascular resistance, there is a resistance to ventricular emptying and more workload for the left ventricle, which responds with hypertrophy of the myocardium. This process differs from the physiologic myocyte response to increase workload exercise in which the workload is intermittent rather than sustained, resulting in an increase in muscle mass but no distortion of the cardiac architecture. Sustained afterload leads to the pathologic hypertrophy, which is characterized by myocyte death, fibrosis, inflammation, and alteration in cardiac energetics, and is mediated by angiotensin II, catecholamines, and changes in intracellular signaling within the myocyte. This pathologic increase in muscle mass results in an increase in oxygen and energy demand. When demand for energy is greater, then the ability of these systems to supply the necessary ATP, contractility of the myocardium, is compromised. An energy-starved state develops that further contributes to changes in the myocytes themselves and ventricular remodeling that significantly impairs contractility and therefore ventricular function. Remodeling also results in the deposition of the collagen between the myocytes, which can disrupt the integrity of the muscle, decrease contractility, and make the ventricle more likely to dilate and fail. Weakness of the cardiac muscle due to hypertension-induced hypertrophy is called hypertensive hypertrophic cardiomyopathy. As cardiac output falls, renal perfusion diminishes with activation of the renin-angiotensin-aldosterone system, which acts to increase your PVR and plasma volume, thus increasing afterload and preload further. In addition, baroreceptors in the central circulation detect a decrease in perfusion and stimulate the sympathetic nervous system to cause yet more vasoconstriction and to cause the hypothalamus to produce antidiuretic hormone, This vicious cycle of decreasing contractility, increasing workload, and increasing afterload causes progressive worsening of left heart failure. In addition to these hemodynamic interactions, systolic congestive heart failure is characterized by a complex constellation of neurohumoral, inflammatory, and metabolic processes. Your catecholamines, that sympathetic nervous system activation, initially compensates for a decrease in cardiac output by increasing the heart rate and peripheral vascular resistance. However, catecholamines cause numerous deleterious effects on the myocardium, including direct toxicity to myocytes, induction of myocyte apoptosis, myocardial remodeling, downregulation of adrenergic receptors, facilitation of dysrhythmias, and potential or potentiation of autoimmune effects on the heart muscle. Your renin-angiotensin aldosterone system, or angiotensin II, activation of the RAS causes not only increase in preload and afterload, but also causes direct toxicity to the myocardium. Angiotensin II mediates remodeling of the ventricular wall, contributing to sarcomere death, loss of normal collagen matrix, and interstitial fibrosis. This leads to decreased contractility, changes in myocardial compliance, and ventricular dilation. Aldosterone not only causes salt and water retention by the kidney, but also contributes to myocardial fibrosis, autonomic dysfunction, and dysrhythmias. It also has been implicated in endothelial dysfunction and prothrombotic effects. Your arginine vasopressin is also known as antidiuretic hormone and causes both peripheral vasoconstriction and renal fluid retention. These actions exacerbate hyponatremia and edema in heart failure. The arginine vasopressin type 2 antagonists, tolvaptan, is indicated for treatment of heart failure that is resistant to conventional diuretics. Your natriuretic peptide, your atrial natriuretic peptides, ANPs, and B-type natriuretic peptides, your BNPs, are increased and may have some protective effect by decreasing workload or decreasing preload. However, their compensatory mechanisms are inadequate in heart failure. Now I'm just hitting buttons. Your inflammatory cytokines, your endothelial hormones, is potent vasoconstrictor and is associated with a poor prognosis in individuals with heart failure. Your tumor necrosing factor alpha and interleukin 6 is elevated in heart failure and contributes to a myocardial hypertrophy and remodeling. It downregulates the synthesis of vasodilator nitric oxide, induces myocyte apoptosis, and may contribute to weight loss and weakness in individuals with heart failure. Your interleukin 6 also is elevated in individuals with severe heart failure and cardiogenic shock, and may contribute to further deleterious immune activation. Your myocyte calcium transport into and out of and within myocytes is critical to normal contractile function. Changes in calcium ion channels, intracellular transport mechanism in the sarcoplasmic reticulum, and calcium cycling have all been implicated in the decreased myocardial contractility and heart failure. Insulin resistance is a likely contributor to as well as a complication of heart failure. Insulin resistance causes abnormal myocyte fatty acid metabolism and generation of ATP, which contributes to the decreased myocardial contractility and remodeling. Heart failure activates the sympathetic nervous system and RAS, which contributes to insulin resistance. Diabetes contributes to heart failure through disturbed calcium metabolism, oxidative stress, changes in fatty acid and glucose metabolism, and mitochondrial dysfunction. In addition, receptors on myocytes for damaging advanced glycation end products are upregulated in injuries to the heart, including ischemia and reperfusion injury. Measurements of levels of RAGE in plasma or serum may correlate with the degree of heart failure. Unfortunately, many of the new medications used to treat diabetes and insulin resistance have deleterious side effects on cardiac function. Newer agents, such as the sodium glucose cotransporter 2 inhibitors and the incretin-based drugs, are safer and may even reduce hospitalization and mortality from heart failure. The interaction of these metabolic, neurohumoral, and inflammatory processes results in a gradual decline in myocardial function. Pathologically, the heart muscle exhibits progressively changes in myocyte myofilaments, decreased contractility, myocyte apoptosis, and necrosis. Abnormal fibrin deposition in the ventricle wall, myocardial hypertrophy, and changes in the ventricular chamber, geometry, remodeling, and endothelial dysfunction, venous congestion, and worsening renal function all contribute to the pathophysiology of acute heart failure. These changes reduce myocardial function and cardiac output and lead to increased morbidity and mortality. These discoveries have led to the routine use of ACE inhibitors, aldosterone blockers, and beta blockers in the management of heart failure, which has resulted in significant decreases in morbidity and mortality. So, our evaluation, the clinical manifestation of heart failure with a reserved ejection fraction, are the result of a pulmonary vascular congestion and inadequate perfusion of the systemic circulation. Individuals experience dyspnea, orthopnea, cough or frothy sputum, fatigue, decreased urine output, and edema. Physical examination often reveals pulmonary edema, cyanosis, inspirational crackles, and pleural effusions. Hypotension or hypertension, an S3 gallop, and evidence of underlying CAD or hypertension. An EKG and serum troponin should be obtained to evaluate for acute ischemia. A chest X-ray should be obtained to assess heart size and evidence of pulmonary congestion, and echocardiograph to confirm decreased cardiac output and cardiomegaly. Invasive cardiac catheterization to monitor hemodynamics or to document underlying coronary disease may be needed. A serum BNP level should be measured to assist in diagnosing heart failure and to monitor its severity and response to treatment. There's other biomarkers that may aid in the diagnosis and management of heart failure, including cardiac troponins and soluble suppression of tumor origenicity 2 or ST2. Management of heart failure with a reserved ejection fraction is aimed at interrupting the worsening cycle of decreasing contractility, increasing workload, and increasing afterload, as well as blocking the neurohumoral mediators of myocardial toxicity. The acute onset of left heart failure is often the result of acute myocardial ischemia and must be managed in conjunction with the underlying coronary disease. Oxygen, nitrates, and morphine administration improve myocardial oxygenation and help relieve coronary spasm while lowering preload through systemic venodilation. Diuretics reduce preload and are the mainstay of therapy. IV inotropic drugs such as dobutamine and milrinone increase contractility and can help raise the blood pressure in hypotensive individuals. Calcium sensitizing inotropic drugs like levosimendan have shown promise for acute heart failure in selected individuals. ACE inhibitors, which reduce preload and afterload, and IV beta blockers, which reduce myocardial demand, have been found to reduce mortality, but must be used with caution in hypotensive individuals. IV administration of neseritide also improves preload and contractility. However, results of these therapy have been mixed. Individuals with severe systolic failure because of a myocardial ischemia may benefit from acute coronary bypass or PCI. Those with refractory hypertension may be supported with the intra-aortic balloon pump until they can be taken safely to the operating room. The intra-aortic balloon pump is positioned in the aorta, just distal of the aortic valve, and is inflated during diastole to improve coronary perfusion and deflated during systole to reduce afterload. Left ventricular assist devices also can be life-saving. The management of chronic left heart failure also relies on increasing contractility and reducing preload and afterload. In all patients with reduced ejection fraction, ACE inhibitors and beta blockers are indicated to reduce mortality. Salt restriction, loop diuretics, and aldosterone blockers, such as spironolactone and eplerenone, are effective in reducing preload and improving outcomes. ACE inhibitors reduce preload and afterload and have been shown to significantly reduce mortality in chronic left heart failure. ARBs do not improve morbidity or mortality in individuals with heart failure and should be used only in those who do not tolerate ACE inhibitors. Renin inhibitors, such as aliskiren, can be effective in selected individuals. Your beta blockers improve symptoms and increase survival. The new class of medications called uroneprilysin inhibitors also have been developed and when combined with ARBs can improve heart failure outcomes. Pharmacogenetics may improve the individualization of therapies. Anticoagulants and antithrombotics may be indicated in selected individuals, particularly those with intracardiac thrombi or atrial fibrillation. Although many individuals with left heart failure die suddenly from dysrhythmias, prophylactic administration of antidysrhythmias has not been shown to improve survival. In individuals with sustained ventricular tachycardia, amiodarone or ICDs are indicated. Cardiac resynchronization therapy is proving to be an important modality in selected individuals. Coronary bypass surgery, or PCI, may improve perfusion to ischemic myocardium and improve cardiac output. Other types of surgical intervention that improve ventricular geometry may be considered. Left ventricular assist devices have lengthened survival significantly for those with end-stage heart failure. Heart transplant may be the only remaining option. Experimental therapies, including gene and stem cell therapies, are being explored. This leads us to heart failure with a preserved ejection fraction. This is a diastolic heart failure. Heart failure with a non-preserved ejection fraction is a systolic heart failure. So now diastolic heart failure. We are preserving that ejection fraction. This can occur singly or alongside with systolic heart failure. Isolated diastolic heart failure is defined as pulmonary congestion, despite a normal stroke volume and cardiac output. It is the cause of approximately 50% of all cases of left heart failure, and is more common in women. The major cause of heart failure with a preserved ejection fraction include a hyperintention-induced myocardial hypertrophy and myocardial ischemia with resultant ventricular remodeling, hypertrophy, and ischemia caused by a decreased ability of the myocyte to actively pump calcium from the cytosol, resulting in impaired relaxation. Other causes include aortic valvular disease, mitral valve disease, pericardial disease, and cardiomyopathies. Diabetes also increases the risk for diastolic dysfunction. Two areas of pathophysiologic changes in the ventricle have been identified in diastolic dysfunction: a decreased compliance of the left ventricle and abnormal diastolic relaxation. Elusitropy. Decreased ventricular compliance has been linked to changes in myocardial structure, such as that seen with molecular alterations in collagen, which forms the extracellular matrix for myocytes. Another recently identified structural change is because of the abnormalities in an intracellular protein component of the myocyte cytoskeleton called titin. Abnormal lusitropy is caused by changes in calcium transport from myocytes and may be related to the activity of sarcoplasmic reticulum calcium adenosine triphosphate or ATPase. Other pathophysiologic processes implicated include autonomic and endothelial dysfunction. The resultant non-compliant and poorly lusitropic ventricle cannot accept filling with blood without significant resistance and an increase in wall tension. Thus, your heart failure with a preserved ejection fraction occurs because the normal LVEDB is associated with an increased LVEDP. The resultant increase in the left atrial pressure is then reflected proximally into the pulmonary circulation and results in pulmonary edema. The increase in pressure is made worse when ventricular filling is rapid, so symptoms worsen with tachycardia, such as exercise. Individuals with a heart failure with a preserved ejection fraction most often present with dyspnea on exertion and fatigue. If diastolic dysfunction is severe, there may be evidence of pulmonary edema, inspiratory crackles on auscultation, and pleural effusions. Pulmonary hypertension and right ventricular failure may develop. Latent diastole, atrial contraction with rapid ejection of blood into a non-compliant ventricle, may give rise to an S4 gallop. An electrocardiography, or EKG, often reveals evidence of left ventricular hypertrophy, and chest X-ray shows pulmonary congestion without cardiomegaly. There also may be evidence of underlying coronary disease, hypertension, and valvular disease. Diagnosis is based on three factors: signs and symptoms of heart failure, normal left ventricular ejection fraction, and evidence of a diastolic dysfunction. The diagnosis is initially made via an echocardiogram, which demonstrates poor ventricular filling, abnormal relaxation, hypertrophy, and/or left atrial enlargement with normal ejection fraction. Management is aimed at improving ventricular relaxation and prolonging diastolic filling times to reduce diastolic pressure. Physical training, your aerobic weight training, improves endurance and quality of life. Nitrate beta blockers, ACE inhibitors, ARBs, and aldosterone blockers have been used with varying success. However, current guidelines focus on treating hypertension, ischemia, or valvular disease. Outcomes for individuals with a heart failure with a preserved ejection fraction can be as poor as those with systolic heart failure. There has been little improvement in prognosis despite numerous new treatments and trials. Our right heart failure is defined as the inability of the right ventricle to provide adequate blood flow into the pulmonary circulation at a normal central venous pressure. It is often a result from severe left heart failure when the increased left ventricular filling pressure is reflected back into the pulmonary circulation. As pressure in the pulmonary circulation rises, the resistance to the right ventricular emptying increases. The right ventricle hypertrophies in response to the increased workload. However, it undergoes progressive diastolic and systolic deterioration and will dilate and fail. When this happens, pressure will rise in the systemic venous circulation, resulting in jugular venous distension, peripheral edema, and hepatosplenomegaly. Treatment relies on the management of the left ventricle dysfunction, as just outlined. When the right heart failure occurs in the absence of left heart failure, it is caused most commonly by pulmonary hypertension, resulting from diffuse hypoxic pulmonary disease, such as chronic obstructive pulmonary disease and cystic fibrosis, or from primary pulmonary arterial hypertension. The mechanism of this type of right ventricular dysfunction, cor pulmonale, is discussed in chapter 36. Finally, right heart failure can result from right ventricular myocardial infarcts, cardiomyopathies, and pulmonic valvular disease. Management relies on the treating the underlying condition, managing intravascular volume, and assisting right ventricular contractility. Vasodilators may improve outcome in primary pulmonary arterial hypertension. So you have a high output failure. High output failure is the inability of the heart to adequately supply the body with blood-borne nutrients, despite adequate blood volume and normal or elevated myocardial contractility. In a high output failure, the heart increases its output by the body metabolic needs and are still not met. Common causes of high output failure is anemia, septicemia, hyperthyroidism, and beriberi. Anemia decreases the oxygen carrying capacity of the blood. Metabolic acidosis occurs as the body's cells switch to an anaerobic metabolism. In response to metabolic acidosis, heart rate and stroke volume increase in an attempt to circulate blood faster. If anemia is severe, however, even maximum cardiac output does not supply the cells with enough oxygen for metabolism. In septicemia, disturbed metabolism, bacterial toxins, and the inflammatory process cause systemic vasodilation and fever. Faced with the lower systemic vascular resistance and an elevated metabolic rate, cardiac output increases to maintain blood pressure and prevent metabolic acidosis. In overwhelming septicemia, however, the heart may not be able to raise its output enough to compensate for vasodilation, the septic shock. Body tissues show sign of inadequate blood supply despite a very high cardiac output. Hyperthyroidism accelerates cellular metabolism through the action of elevated levels of thyroxine from the thyroid gland. This may occur chronically, thyrotoxicosis, or acutely, a thyroid storm, because the body's increased demand for oxygen threatens to cause a metabolic acidosis. Cardiac output increases. If blood level of thyroxine are high and the metabolic response to thyroxine is vigorous, even an abnormally elevated cardiac output may be inadequate. In the US, beriberi or thiamine deficiency usually is caused by malnutrition secondary to chronic alcoholism. Beriberi actually causes a mixed type of heart failure. Thiamine deficiency impairs cellular metabolism in all tissues, including the myocardium. In the heart, impaired cardiac metabolism leads to an insufficient contractile strength. In blood vessels, thiamine deficiency leads mainly to a peripheral vasodilation, which decreases your SVR. Heart failure ensues as decreased SVR triggers increased cardiac output, which the impaired myocardium is unable to deliver. The strain of demand for increased output in the face of impaired metabolism may deplete cardiac reserves until low output failures begin. This leads us to dysrhythmias. A dysrhythmia or arrhythmia is a disturbance of the heart rhythm. Normal heart rhythms are generated by an SA node and travel through the heart's conduction system, causing the atrial and ventricular myocardium to contract and relax at a regular rate that is appropriate to maintain circulation at various levels of physical activity. Dysrhythmias range in severity from occasionally missed or rapid beats to serious disturbances that impair the pumping ability of the heart, contributing to heart failure and death. Dysrhythmias can be caused by either an abnormal rate of impulse generation by the SA node or other pacemaker, or by the abnormal conduction of impulses through the heart's conduction system, including the myocardial cells themselves. The pathophysiology, diagnosis, and treatment of dysrhythmias are highly complicated. Atrial fibrillation provides an example of many factors that must be considered. And then there is bradycardia, sinus tach, premature atrial contractions or beats, sinus dysrhythmias, atrial tachycardia, atrial flutter, atrial fibrillation, an idiojunctional rhythm, a junctional bradycardia, a premature junctional contraction, accelerated junctional rhythm, a junctional tachycardia, idioventricular rhythm, ventricular bradycardia, an agonal rhythm, ventricular standstill or asystole, premature ventricular contractions or PVCs, accelerated ventricular rhythm, ventricular tachycardia, ventricular fibrillation. And talking about cardiac blocks. Sinus block, E first degree, E second degree, type 1 and type 2, a third degree, an atrioventricular dissociation and ventricular blocks, aberrant conduction, a pre-excitation syndrome, and some education on AFib. But I think this concludes our chapter, so thank you for listening, and we'll see you at the next chapter. So until then, thank you, and have a good day. Bye.